high principles in psychiatry. Okay. Uh, Psychology, classical conditioning, learning in which a natural response or salivation is elicited by a conditioned or learned stimulus, bell, that previously was presented in conjunction with an unconditioned conditioned stimulus like food. So usually elicits involuntary responses. This is the Pavlov's classical experiment with dogs. When he rang the bell, the dog started salivating, right? Because first he would ring the bell and then present the food, and then the dog understood that whenever the bell rings, he would get food. So the brain would make the dog start salivating as soon as they hear the dog hears the bell. Okay, so that's called classical conditioning. Operant conditioning, it's learning in which a particular action is elicited because it produces a punishment or reward. Usually elicits voluntary responses. Okay. Reinforcement, target behavior or response is followed by desired reward. Okay, so whatever they want out of a person, then they reward it, right? Like, uh, I have examples over here, so I'll read that after. So positive reinforcement or removal of aversive stimulus. This is called the negative reinforcement. Then there's punishment. It's repeated application of aversive stimulus, so positive punishment, or removal of desired reward, negative punishment, to extinguish wanted behavior. Right, and then extinction is discontinuation of reinforcement, positive or negative, eventually eliminates behavior. Can occur in operant or classical conditioning. Okay, so after a while, when they don't, dog doesn't get the food, even though the bell is ringing, the dog's gonna stop salivating, even when the bell rings. Right. Skinner operant conditioning quadrant. So you make this quadrant in your head, and then it helps you to understand which one's which. So they'll give you a scenario, and then you just plug it into this square, and then you'll get your answer. So increase behavior and decrease behavior. Okay. Add a stimulus or remove a stimulus. Okay. So to increase behavior, you add a stimulus. It's called positive reinforcement. It's like getting a promotion for good work. Okay. Then we have this as well. So positive reinforcement, it's stimulus added to the environment. Now future probability of the behavior will increase for this, right? Uh, then to decrease a behavior, you add a stimulus like spanking a child. This is positive punishment, so spanking a child for his behavior. Right, so positive punishment is over here. Stimulus added to the environment, again same thing, right? Stimulus added to the environment, these are positive reinforcement or punishment. So whenever it's positive, it's a stimulus added. Okay, and then reinforcement, it's future probability of the behavior will increase, and punishment, future probability of behavior decreases, right? So yeah, spanking a child for his behavior, or uh, yeah, or hitting a child for doing something odd, like crying in the supermarket to buy a toy or something. Then to increase a behavior, you remove a stimulus. So this is called negative reinforcement. Negative, that means stimulus is removed from the environment. Reinforcement, that means the future probability of behavior will increase. Okay. So that's like strengthen a behavior that avoids or removes a negative outcome. So child pouts and parent takes away veggies, right? So child is doing negative reinforcement on the parents, like that. Uh, okay. Then there is negative punishment. So stimulus removed from the environment, so future probability of the behavior will decrease. Okay. Uh, so take away video games after misbehavior, like that. So this one and this one sounds a little of the same thing, right? But here you're adding something. So you're doing something and adding a stimulus, whereas this you're taking away a stimulus, right? Like taking away the video game. So the probability, so punishment is a probability of the behavioral decrease, right? In this and this. Does that make sense? Okay, so Skinner operant condition quadrants. It's this. Okay. Transference and countertransference. Transference is redirect feelings of one person onto another, associating person in the present with the person in the past. So patient projects feelings about formative or other important persons onto physician. For example, psychiatrist is seen as a parent. Okay. And then countertransference is the physician projecting his feelings about formative or other important person onto the patient. For example, patient reminds physician of a younger sibling. Right. And now the ego defenses. Okay, there are two type of ego defenses. They're mature and immature. Okay, so ego defenses are thoughts and behaviors. They could be voluntary or involuntary or conscious or subconscious. Used to resolve conflict and prevent undesirable feelings like anxiety or depression. Okay, so conflict could be, their feelings as well. Oh, right? It's not just, conflict by itself. So conflict and prevent undesirable feelings. For example, anxiety and depression. To get over that, um, they do certain things. Okay, and there are many things that you can do to, you know, avoid uh, undesirable feelings. Okay, so immature defenses, description, and example. So immature number one, acting out, subconsciously coping. So let's do this. We'll read the defenses and then example and then read the description for it. So acting out, it's a patient skips therapy appointments after deep discomfort from dealing with his past. Right. So this is subconsciously coping with stressors like the past or emotional conflict using actions rather than reflections uh, or feeling. So rather than, reflecting on why it's happening and stuff, they're just, running away from the situation. So they're skipping appointment. Okay. And this is acting out. So it's when they're, rather than dealing it with, you know, with reflections or feelings, they're converting it into something physical, like not going to therapy. Okay, so if it's something physical, it's going to call acting out. Okay, let's look at other examples of acting out. A student learns he failed a course, smashes a window in the classroom, right? Rather than working out the feelings, he's doing something physical and converting it into something physical. So, or whistling in the dark hides the real underlying fear. That's also acting out. Okay. Another example, instead of saying I'm angry with you, a person who acts out may instead throw a book at the person, right? Rather than, reflecting on the feeling and talking it out, it's something physical. For instance, a child's temper tantrum is a form of acting out when he or she doesn't get his way or her way with a parent. Self injury may also be a form of acting out, expressing in physical pain what one cannot stand to feel emotional. Okay. Denial. A patient with cancer plans a full-time work schedule despite being warned of significant fatigue during chemotherapy. Okay, so they're in denial basically, right? This is avoiding the awareness of some painful reality. So they're not acknowledging the reality, and they're in denial. Okay, let's look at a few more examples of that. An alcoholic fails to acknowledge that he is addicted to alcohol. Heavy smokers, individuals may refuse to admit that smoking is bad for their health. Right, so they're uh, in denial there. A smoker refusing to acknowledge cough. Yeah. A patient continuing to smoke after being informed of his lung cancer diagnosis. Right. Okay, so that's denial. Displacement. Okay, that's after being reprimanded by her principal, a frustrated teacher returns home and criticizes her wife's cooking instead of confronting the principal directly. Uh, some people are confused about this sentence on the group. It's two wives or two girls or women married to each other. Right, that's what that is. So she was wife number one was reprimanded by the principal, and her wife uh, got the other end of the anger. So redirection of emotions or impulses to a neutral person or object versus projection. Okay, displacement. Displacement is the shortest. No, that doesn't work. Displacement defense mechanism. Okay, the transfer of negative emotion from one person or thing to an unrelated person or thing. Right, so boss shouts at Ankita, shouts at husband. Okay, seems like all of these are similar examples. Unable to express anger to the boss for fear of being fired displaces that. You know, uh, it could be just a situation that they're in or problem. It doesn't have to be this, right? It's all about the boss, isn't it? I'm sorry, Bob, you're not getting that promotion. Robert, it's not nice to get mad at your elders. Okay, so next time, young man, you're not getting dinner. Okay, so that's like that. Okay, I guess that's it. Dissociation. This is a survivor of sexual abuse sees the abuser and suddenly becomes numb and detached. Okay, so that's temporary drastic change in personality, memory, consciousness, or motor behavior to avoid emotional stress. Patient has incomplete or no memory of traumatic event. Okay. Okay. Temporary drastic change in personality, memory, consciousness, or motor behavior to avoid emotional stress. Patient has incomplete or no memory of traumatic event. Okay. Dissociation. Okay. Amnesia. That doesn't help. A person's ego avoids the fear caused by a traumatic experience by disconnecting that. Yeah. A man's superego provokes such strong feelings of guilt and shame when he wants to be a cross dresser. that his ego is forced to accommodate the strong desire by creating a separate cross-dresser personality. Uh, these are getting too deep into it. We won't need to, we won't be given examples like these. Okay. People who have a history of any kind of childhood abuse often suffer from some form of dissociation. Any situation that might be similar to the original trauma might make them automatically go to their mental happy place. Okay. Uh, that's dissociation. They basically dissociate from themselves, right? Because by itself, the word means the disconnection or separation of something from something else, or the state of being. Okay. Fixation. Okay. So, okay, so I kind of wrote the description, I guess, over here. So for immature defenses, doesn't understand or don't understand the reality and unaware of things, if that helps. Whereas mature is aware of the reality and more sophisticated decisions, therefore. Okay, so fixation. A college student studying for a stressful exam begins sucking her thumb or biting nails, right? Or biting nails is also a fixation. So partially remaining at a more childish level of development versus regression. Okay, so regression is over here. Yeah, so fixation is like biting nails during a stressful time. Okay. Idealization. So a patient boasts about his physician and his accomplishments while ignoring any flaws, right? Description: expressing extremely positive thoughts of self and others while ignoring negative thoughts. Kind of like, I don't know, the MAGA party or the Trump's party supporters, or Modi bucks from India. Uh, I guess I'm one of them too. But yeah, that's idealization. Let's see a few more examples of these. Okay. Attributing exaggerated positive qualities to self to others. Wouldn't that be narcissism though? No idealization over there. There's displacement, so someone who is frustrated from. I'll be right about that one. Nothing for that. So, uh, it's pretty easy to figure out because by itself, idealization means the action of regarding or representing. Okay. Identification. A resident starts putting her stethoscope in her pocket like her favorite attending, instead of wearing it around her neck like before. So largely unconscious uh, assumption of the characteristics, qualities, or traits of another person or group. Right. That's different than idealization because this is boosting about it and ignoring the flaws, whereas identification is they start picking up habits of the other, someone who they idealize, or their favorite person. Intellectualization. It's a patient diagnosed with cancer discusses the pathophysiology of the disease, right? So using facts and logic to emotionally distance oneself from a stressful situation. This one's kind of tough because it feels like we do this all the time, but we're usually aware of the reality when we do it, right? These people are not, who use this ego defense, they're not really aware of the reality. They're just trying to, avoid the reality. So they're discussing stuff around what the reality is. Okay. That's called intellectualization. Uh, it's like they don't want to know about it, basically. Okay. That's the same kind of example. Okay. A young professor receives a letter from his fiancée breaking off their engagement. He shows no emotion when discussing this with his best friend. Instead, he analyzes his fiance's behavior and tries to reason why the relationship failed. Okay. New widow or sexual assault victim. Problem if it goes on too long. Don't deal with emotions. That's dissociation, intellectualization. May accompany but differ from rationalization, which is validation. Nope. Examples. Okay. Husband constructing elaborate logical explanations for wife's recent paranoia idea. Right? So, um, yeah. If the wife comes in, those horror stories where they're like, I heard a noise or the lights were going on and off at night while you were sleeping. The husband is like, yo, it's no problem. It's because of this, probably, or there was surge or something. And then the wife gets pulled away in the dark by the ghost. Intellectualization, right? Okay. Isolation of affect. Describing murder in graphic detail with no emotional response. Okay. So separating feelings from ideas and events. Uh, this one is you should be able to differentiate between this and dissociation. Okay. So over there you would drastic change and all that stuff. But then you don't have the memory in this one. Whereas in isolation, it's separating the feelings from ideas, and you remember everything. So you're describing like a third party. Okay. Passive aggression. It's a disgruntled employee is repeatedly late to work but won't admit it as a way to get back at the manager. So, demonstrating hostile feelings in a non confrontational manner, showing indirect opposition. Okay. Projection. A man who wants to cheat on his wife accuses his wife of being unfaithful. It's attributing an unacceptable internal impulse to an external source. Right? So, this is not a feeling, it's an impulse. It's something they want to do. Right? Uh, if you don't know, impulse is a sudden, strong, unreflected urge or desire to act. Okay. Uh, so it's a feeling of doing something or a feeling or a urge to do something. Okay. So that's the main thing. Whereas in displacement, it was, you know, their feeling about someone else and, a negative feeling about someone else and then displacing it onto their spouse, right? So that's the difference there. With projection, it's the impulse and not the feeling. So attributing an unacceptable internal impulse to an external source versus displacement. A man who wants to cheat on his wife accuses his wife of being unfaithful. Okay. So it could be like, a man who's been working all weekend. He wants to go out with his boys, and so he's asking the wife to go out with her girls, to have a girls' night out or something, because she has been working so hard at home. That's also projection. It's not that uh, he really cares about it. It's just that he wants to go out and have his time, so he's telling his spouse to also do the same or try to. That could be projection as well, that she has been working as hard as he has or something like that. or vice versa. She has been working hard, and then she tells the guy. Okay. Rationalization. An employee who was recently fired claims that the job was not important anyways. Right. So that's sort of like, there's a story in India. It's about how a fox was trying to get a fruit from the tree, but then he couldn't get it. So then it's like, it looks pretty sour anyways, and walks away. So asserting plausible explanation for events that actually occurred for other reasons. It's because the fox couldn't make it, right? Usually to avoid self-blame, not that, you know, doesn't want to admit that he can't climb the tree, or the fox couldn't climb the tree or something. Okay, so yeah, rationalization. This is different than intellectualization. Okay, so using facts and logic to emotionally distance oneself from stressful situation. You should be able to differentiate between those two. Let's see if there's one for this. Okay. Excuse and justifies mistakes. That's rationalization. See, displacement, taking it out on someone else. Identification attached to something positive. Introjection, we don't do that one. Projection, see your faults and uh, foibles in others. Rationalize, excuse, and justify. We haven't done these yet. Okay. So making something wrong sound right. That's basically what that is. Uh, a student who cheats on a test may say, I only cheated on a few questions, I knew most of the answers. Or, I only cheated because everyone else was cheating as well. Something like that too. Uh, Making excuses. A parent punishes a child and says that it is for the child's own good. That's rationalization. If I had better teachers, I would have gotten higher grades. A student who cheats on tests may say, I only cheated on a few questions, I know most of the answers. Okay. Reaction formation. It's replacing, sorry. Okay, so a stepfather treats a child he resents with excessive nurturing and overprotection. Okay, so replacing a warded off idea or feeling with an emphasis on its opposite. Okay, versus sublimination. That's a mature defense mechanism. Okay, so that's basically it. It's a feeling they have about someone, but then they overcompensate for it. Uh, so a person who is angry with a colleague actually ends up being particularly courteous and friendly towards them. Someone frightens you, so you act super nice. Someone frightens you, so you snub them. The sex offender becomes the great protector of society. uh, False persona, that's what it is. Acting like you hate someone you'd really have a crush on, so that's also reaction formation. And yeah, thanks but no thanks. Playing hard to get doesn't get easier. Okay. A woman who loves an unattainable man and behaves as though she hates him. That's like a rom-com right there. But guess you make sense now. We haven't done these yet, so we'll do those now. Regression. It's a previously toilet trained child begins bedwetting again following the birth of a sibling. So involuntary turning back the maturational clock to behaviors previously demonstrated under stress. Okay, so this could also be, throwing tantrums in a OT, right? In a operating theater, surgeon throws tantrums because he's getting stressed out. That could also be regression. Let's see other. So tantrum, as long as it's, just yelling. Otherwise, when he starts throwing things, that's also called the acting out. Riveting to sucking your thumb. We know that one. A child may begin to suck their thumb or wet the bed when they need to spend some time in the hospital. Okay. Or, someone who pisses their pants because of a stressful situation. Or, you know, shitting your pants. That's a term people use. Okay. An individual fixated on the oral stage might begin eating or smoking excessively, or might become very verbally aggressive after going through divorce. Okay, that doesn't help. Anyways, we got it. Going on to repression. Repression is like a 20-year-old who does not remember going to counseling during his parents' divorce 10 years earlier, right? So, this is the type of amnesia you get uh, due to depression, right? Because depression can cause amnesia as well, sort of like that. So involuntarily withholding an idea or feeling from conscious awareness versus suppression. Is that it? And at least, yeah, so that's repression. See examples of that. During the OPD's complex aggressive thoughts about the same-sex parents are repressed. Okay, repression is an unconscious mechanism employed by ego to keep disturbing or threatening thoughts from becoming conscious. Okay. Your desire for an inappropriate person. So suppressing unwanted thoughts and information from consciousness. Right. So anything that you're just, repressing it from the conscious awareness. So suppression. Splitting. Believing. Okay. So it's patient says that all the nurses are cold and insensitive, but the physicians are warm and friendly. So this one is pretty easy to figure out in a vignette because it's gonna be right there. It's black and white with them. So they'll say that when I went to this hospital, this is usually the example they use anyways, but all the nurses were really horrible and terrible and hostile, whereas the doctors were really kind and warm and welcoming. You know, that's splitting. They're splitting people into good and bad. So believing the people are either all good or all bad at different times due to intolerance of ambiguity, common in borderline personality disorder. Okay. Uh, so they could give you an example of splitting and ask you what disorder is this. So it could be borderline personality disorder. Okay. Mature defenses. So they're aware of the reality and choose a more sophisticated way to deal with it. So sublimination. Uh, Teenagers' aggression towards her parents become because of their high expectations is channeled into excelling in sports. So replacing an unacceptable wish with a course of action that is similar to the wish but socially acceptable, right? Versus, overcompensating for that feeling, like reaction formation. Altruism. Uh, a mafia boss makes a large donation to charity. Right? It's alleviating negative feelings via unsolicited, solicited generosity, which provides gratification versus reaction formation. Okay, uh, that's a fun one. Suppression. An athlete focuses on other tasks to prevent worrying about an important upcoming match. Okay, uh, so this is a tough one to differentiate between this and what was it? Repression, right? So involuntarily withholding an idea or this from the conscious mind. It's hard to differentiate between the two in a given scenario, but this one they don't acknowledge it at all. So it's kind of like an amnesia, right? Whereas this one they know about it, they're just choosing not to think about it because it's affecting their other day-to-day life or tasks. Okay, so intentionally withholding an idea or feeling from conscious awareness versus repression. So it's temporary. That's important. Okay, so an athlete focuses on tasks. Let's see if there are other examples of these. There's no suppression here, but there's sublimation. Satisfying an impulse like within a substitute object in socially acceptable way. Sport is an example of putting our emotions, for like aggression, into something constructive. So repression and suppression. Repression is unwanted impulse or thoughts being unconsciously pushed out of awareness, deliberately trying to forget or not think about painful or unwanted thoughts. Okay, no suppression here. Okay. Thinking about all those sweets in the staff lounge and wanting to eat them while on a diet. Okay, so you're suppressing that urge, I guess. So repression, that's a good one. A man is jealous of his good friend's success but is unaware of his feeling of jealousy. Okay. No suppression there either. But yeah, I guess we got that one. And then there's humor. So a nervous medical student jokes about the boards. So yeah, uh, that should hit home. Lightheartedly expressing uncomfortable feelings to shift the internal focus away from the distress. Okay, so mature adults wear a sash. So sublimation, altruism, suppression, and humor. So these are all the mature defenses, and the immature ones are all of these. Okay. Grief. It's a natural feeling that occurs in response to the death of a loved one. Symptoms and trajectory vary from each individual and are specific to each loss and do not follow a fixed series of stages, in addition to guilt, sadness, and yearning. Uh, Patients may experience somatic symptoms, hallucinations of the disease, and or transient episodes of wishing they had died with or instead of their loved one. So with this, you gotta be able to figure out if it's normal grief or it's something like a depressive disorder. Okay, so for grief, it typically lasts for 6 months, right? So typically acute grief is time limited, so adaptations within 6 months, and is not a disorder. Complicated grief, so persistent complex bereavement disorder. Bereavement is the fact or condition of being bereaved. There is no right way of explaining. So we need to know what bereave means. It's just grieve actually. deprived of a loved one through a profound absence, especially due to the loved one's death. Okay, so it's in the name. Persistent complex bereavement disorder. It can be diagnosed if thoughts are persistent and prolonged, significantly impair functioning, and do not meet criteria for another disorder. So you have to be able to, uh, cross this one out before you pick this one. So you gotta differentiate between the two. So yeah, major depressive disorder. Okay. Normal infant and child development. For this, I don't worry about these because they're hard to remember, and I remember it this way. Uh, so Dirty Medicine goes through these, and he made up these. So this is all I do. So I'm not gonna bother reading up on these things, but I'll read this. So for gross matter motor, it's 2 months, 4 months, 6 months, 9 months, and 12 months. Right. So he made a little song for this. So first 2 months it's raise head, so they can raise their head. 4 months they roll over. 6 months sits up. 9 months crawl. 12 months walks. So they start walking at 12 months, right? For this, the question is gonna be like something, it's not gonna be asking about this. It's gonna be in the vignette itself. They're gonna come in and they're gonna be like, uh, a baby's gonna have all these bruises and stuff, and then doctor asks about them, and they say, the baby who's 2 months old, she accidentally rolled over the edge of the bed and fell, and that's how she got the bruises. So what would your next thing would be? It would be to call child farewell or welfare, sorry, services, right? Because they can't roll over until they're 4 months. So, and the child is only 2 months. So that's how you'd know that. Okay, so the song is 2 months old. Hold on. I suck at singing, so fair warning. 2 months old, raise your head. 4 months old, roll over, Fred. 6 months sit up, 9 months crawl. 12 months walk, and that's all. I don't know. He uses a different melody. I don't remember it, but this works. Okay. To remember these, they sit up at 6 months and crawl at 9 months. I think it was the tune of Happy Birthday, but I'm not gonna embarrass myself with that. So, for language, uh, so at 2 months it coos, 4 months it haha, 6 month babbles, 9 months mummy dada, and 12 months is one plus words. Okay, so the month is associated with the number of letters. Okay, so 2 letters, so it coos. Baby coos at 2 months. Uh, it laughs, or at 4 months. At 6 months, it starts babbling. At 9 months, it starts saying mama dada, or mom and dad, but mama dada or something like that. And by 12 months, they have increased vocabulary than more than one word. In social, 2 months, 4 months, 6 months, 9 months, 12 months again. Here, the first letter of these months for social represents the letter of the word. Okay, so 2 months it twinkles, 4 months it focuses on sound. At 6 month, S is for stranger anxiety. 9 months, N for name, and 12 months is told command and it responds. So at 9 months, when they call out their name, they respond to it. They'll look over or something, and at 12 months, when they're told to sit down or stand up or come here, they'll listen to it. So told command, they respond to it. Okay, so gross motor, 2 months old, raise your head. 4 months old, roll over, Fred. 6 months sit up, 9 months crawl. 12 months walk, and that's all. Okay, shut up. Laughs. So no language. It's 2 month coos, 4 month haha, 6 month babbles, 9 month mommy dada, and 12 months is one plus word. Social is 2 month twinkles, 4 month focuses on sound. At 6 month, stranger anxiety. 9 months, name response, and 12 months is told commands and response to it. Okay. On to child abuse. Okay, so sign. Physical abuse. So there's physical abuse, sexual abuse, and emotional abuse. In physical abuse, it's gonna be non-accidental trauma, for example, fracture, bruises, or burns. Injuries often in different stages of healing or in patterns resembling possible implements of injury. It includes abusive head trauma, shaken baby syndrome, characterized by subdural hematomas. So that's important. If you see subdural hematomas, uh, remember these are the ones where it crosses the fissure lines, whereas the dural hematoma, hold on, what epidural ones, they don't cross the fissure lines. Okay, so characterized by subdural hematomas, and so shaken baby syndrome, or retinal hemorrhages. So you should be able to figure out if it's a shaken baby syndrome or not. Caregivers may delay seeking medical attention for the child or provide explanation inconsistent with the child's development stage or pattern of injury. So this is the example I gave. 2-month-old baby rolled over the bed and hits his head. Right. So epidemiology. So 40% of deaths related to child abuse or neglect occur in children less than 1 year old. Okay. And sexual abuse. So the signs are STIs, UTIs, or genital, anal, or oral trauma. Most often, there are no physical signs. Sexual abuse should not be excluded from a differential diagnosis in the absence of physical trauma. Okay, so then you can, ask questions, and you'll see that children often exhibit sexual knowledge or behavior incongruent with their age. So it's not, something they should know for their age. Okay, so incompatible or incongruous. Epidemiology, at peak incidence is 9 to 12 years old. Okay. Emotional abuse. Babies or young children may lack a bond with caregiver but are overly affectionate with less familiar adults. They may be aggressive toward children and animal or unusually anxious. Other children are often emotionally liable and prone to angry outbursts. They may distance themselves from caregivers and other children. They can experience vague somatic symptoms for which a medical cannot be found. Okay. Right. So again, babies or young children may lack a bond with the caregiver but are overly affectionate with less familiar adults. Uh, that's kind of like Williams disease, isn't it? They may be aggressive toward children and animals or unusually anxious. Older children are often emotionally liable uh, or labile and prone to angry outbursts. They may distance themselves from caregivers and other children. They can experience vague somatic symptoms for which a medical cause cannot be found. Epidemiology. Approximately 80% of young adult victims of child emotional abuse meet the criteria for one or more psychiatric illnesses by the age of 21. There's child neglect. It's failure to provide a child with adequate food, shelter, supervision, education, and or affection. Most common form of child maltreatment. Signs are poor hygiene, malnutrition, withdrawal, impaired social emotional development, and failure to thrive. Okay, so this is what you will see in the scenario, or there will be poor hygiene, malnutrition, withdrawal, impaired social or emotional development, and failure to thrive. There's a video of this of child neglect on YouTube where they bring in children and they check their behavior and ask questions and all that, right? So it's, heartbreaking, but if you want to check it out. Vulnerable child syndrome. um, Parents perceive the child as especially susceptible to illness or injury versus fictitious disorder imposed on another. Usually follows a serious illness or life threatening event, can result in missed school or overuse of medical service, right? So, this is the complete other side of the spectrum from child neglect. This is overprotectiveness, right? So they perceive the child as especially susceptible to illness or injury. Okay, usually follows a serious illness or life-threatening event, can result in missed school or overuse of medical services. Fictitious disorder, it's when they don't have any problem and they just, tell other people that they do, and all that stuff. For this one, I'll show you the link to that. This one, uh, this is the one I was talking about. So, effect of emotional deprivation and neglect on babies. Let's see if we can put it up a little. Oh, they're so cute. Yeah, I can't watch that, but you guys can do that, or can watch something like this. This is too long, but this one's pretty good if you want to understand all that stuff. Otherwise, I'll take a break here and then we'll come back and continue from here. Childhood and early onset disorders. So, attention deficit hyperactivity disorder or ADHD. Onset before age 12, but diagnosis can only be established after age 4. Characterized by hyperactivity, impulsivity, and or inattention in two or more settings like school, home, place of worship, right? So that's what the scenario is gonna be like. The child is hyperactive and at home and at school, and the teacher complains of it all the time, right? Normal intelligence, but commonly coexists with difficulty in school. Often persists into adulthood, commonly coexists with oppositional defiant disorder. Treatment is stimulants, for example, methylphenidate, with or without behavioral therapy. Alternatives include atomoxetine and alpha 2 agonists, for example, clonidine and guanfacine. Right, so alpha 2, there was a mnemonic for this that I gave, and atomoxetine. But behavioral therapy is the popular one, anyways. Okay, and stimulants. So if the dude is already like hyperactive, why would you give stimulant, right? But so you might forget about that one. But remember, you give stimulant in ADHD. That's methylphenidate. Autism spectrum disorder. Onset in early childhood. Social and communication deficits. Um, Repetitive, ritualized behavior, restricted interest. May be accompanied by intellectual disability and or above average ability in specific skills, for example music, or astronomy as well, like they're always looking at the stars through telescope and stuff like that. More common in males, associated with increased head and or brain size. Okay. Conduct disorder. So repetitive, pervasive behavior violating societal norms or the basic rights of others. For example, aggression towards people and animals, destruction of property, and theft. So after age 18, it's often reclassified as antisocial personality disorder. Okay. So this is you only pick this if the patient is less than 18-year-old. If it's more than 18, it's going to be this one. Treatment, psychotherapy. For example, cognitive behavioral therapy or CBT. Disruptive mood dysregulation disorder, so onset before age 10, severe recurrent temper outbursts out of proportion to situation. Child is constantly angry and irritable between outbursts. Treatment is CBT, stimulants, antipsychotics. Okay. Uh, so this is onset is before 10. Severe recurrent temper outbursts out of proportion to situations. This is different than conduct disorder, right? This one's behavioral, um, right? It's like you can see the physical build up to of this trait, whereas this it's temper outbursts, okay, and it's going to be out of proportion. Intellectual disability, it's global cognitive deficit versus specific learning disorder that affect reasoning, memory, abstract thinking, judgment, language, learning. Adaptive functioning is impaired, leading to major difficulties with education, employment, communication, socialization, and independence. Treatment is psychotherapy, occupational therapy, special education. Okay. Intermittent explosive disorder, onset after age 6. Recurrent verbal or physical outbursts represents a failure to control aggressive impulse. The ages, it's alright if you don't remember the age, by the way. It only matters in conduct disorder and uh, hyperactivity disorder. Okay, so intermittent explosive disorder, its onset is after age 6. Recurrent verbal or physical outbursts representing a failure to control aggressive impulses. Outbursts last less than 30 minutes and are out of proportion to provocation and may lead to legal, financial, or social consequences. Episodes are not premeditated and provide an immediate sense of relief, followed by remorse. Okay, so uh, like a guy getting, mad at a girlfriend or something like that. That could be this as well. And it's been happening since they were 6 years of age. And then they're always like sorry after the episode is done, right? Treatment is psychotherapy and SSRIs. Oppositional defiant disorder, pattern of anger and irritability with argumentative, vindictive, and defiant behavior toward authority figures lasting more than 6 months. Okay. Treatment is psychotherapy, for example, CBT. Okay. Uh, so oppositional defiant disorder. How is this different than antisocial one? It's similar to that one, but this one, behavior towards authority lasting more than 6 months, I guess. That's the given point. Okay. Now, selective mutism. It's onset before age 5. Anxiety disorder lasting more than 1 month involving refraining from speech in certain situations despite speaking in other, usually more comfortable situations. Development is, for example, speech and language are not typically impaired. It interferes with social, academic, and occupational tasks. Commonly coexists with social anxiety disorder. Treatment is behavioral, family and play therapy, and SSRIs. Separation anxiety disorder, it's overwhelming fear of separation from home or attachment figure lasting more than 4 weeks, can be normal behavior up to age 3 to 4, may lead to fictitious physical complaints to avoid school. Treatment is CBT, play therapy, or family therapy. Uh, Specific learning disorder, onset during school age years, inability to acquire or use information from a specific subject, for example, math, reading, or writing, near age expected proficiency for more than 6 months, 6 or more months, despite focused intervention. General functioning and intelligence are normal versus intellectual disability. Treatment is academic, sport, counseling, extracurricular activities. Tourette syndrome, its onset before age 18, sudden, recurrent, non-rhythmic, stereotyped motor. For example, grimacing, shrugging, and vocal. For example, grunting and throat clearing. Tics that persist for more than 1 year. For this, you can watch like a YouTube video, and once you watch it, you won't forget what Tourette's is. Tics that persist for more than 1 year. Uh, Coprolalia. This is involuntary obscene speech found in some patients associated with OCD and ADHD. Treatment is psychoeducation, behavioral therapy for intractable and distressing tics, tetrabenazine, antipsychotics, and alpha 2 agonists. Okay, this is uh, way to remember the ages, so or like childhood disorders. So selective mutism happens more than 1 month. Separation anxiety keeps on going after 1 month. ADHD starts if it's more than 6 months. Specific learning and oppositional defiant. And then tic disorder and disruptive mood dysregulation is more than 1 year. That's when you would diagnose it. Okay, orientation. Patient's ability to know the date and time where they are and who they are, order of loss, time, place, and person. Common cause of loss of orientation. Of loss and orientation: alcohol, drugs, fluid electrolyte imbalance, head trauma, hypoglycemia, infection, and nutritional deficiency and hypoxia. Okay. Amnesias. So there are two types: retrograde and anterograde. Retrograde amnesia is inability to remember things that occurred before an CNS insult. Anterograde is inability to remember things that occurred after CNS insult. Okay, so decreased acquisition of new memory. And Korsakoff syndrome. This is amnesia, anterograde more than retrograde. Mostly, they can't make new memories. Okay, and disorientation caused by vitamin B1 deficiency, associated with disruption and destruction of the limbic system, especially mammillary body and anterior thalamus, seen in chronic alcohol use as a late neuropsychiatric manifestation of Wernicke encephalopathy, and confabulations are characteristic. Okay, know what that is and remember that, because that gets asked by itself as well. That Korsakoff or dude drinks a lot, so what kind of deficiency would you see? Dissociative disorder, depersonalization or derealization disorder. Uh, okay, so D for detachment. So it's persistent feelings of detachment or estrangement from one's own body, thoughts, perception, and actions, or depersonalization or one's environment, derealization. Intact reality testing versus psychosis. Dissociative amnesia, it's inability to recall important personal information, usually following severe trauma or stress, may be accompanied by dissociative fugue. This is abrupt, unexpected traveling away from home. Dissociative identity disorder, these are formally called multiple personality disorder, presence of more than two or more distinct identities or personality states, typically with distinct memories and behavior of pattern of behavior. More common in females, associated with a history of sexual abuse, PTSD, depression, substance abuse, borderline personality disorder, and somatic symptom disorders. Um, Previously was called split personality, right? That's this one. Famous movie on that too. Split. Delirium. Delirium is waxing and waning level of consciousness with acute onset, decreased attention span, decreased level of arousal, characterized by disorganized thinking, hallucinations, often visual, misperception, for example, illusions, disturbance in sleep wake cycle, cognitive dysfunction, agitation, and reversible. It's reversible, okay. Usually secondary to other identifiable illness, for example, CNS disease, infection, trauma, substance abuse, withdrawal, metabolic, electrolyte disturbances, hemorrhage, urinary fecal retention, or medication, for example, anticholinergics, especially in older adults. Most common presentation of altered mental status in inpatient setting, especially in ICU or during prolonged hospital stays. This is an important one. You'll see delirium in these people. Delirium changes in sensorium. EEG may show diffuse background rhythm slowing. Treatment is identification and management of underlying condition, orientation, protocol. Uh, for example, keeping a clock or calendar nearby, decrease in sleep disturbances, and increase in cognitive stimulation to manage symptoms. Antipsychotics, for example, haloperidol, as needed, avoids unnecessary restraints and drugs that may worsen delirium. For example, anticholinergics, benzodiazepines, and opioids. Hold on. Okay. Okay. So psychosis. Psychosis is distorted perception of reality characterized by delusions, hallucinations, and or disorganized thought, speech, can occur in patients with psychiatric illness or another medical condition or secondary to substance or medication use. Okay. Uh, this is an important one now. So this is all the stuff that you will be tested on now. This one, it's pretty easy to figure out. They just ask you what is it, so it's easy to figure out which one of these it is. For this, it's also easy to figure out, but these ones it gets complicated now with the psychosis. So because they all have rules and exceptions that you need to be aware of. Okay, so delusions. It's false, fixed, idiosyncratic beliefs that persist despite evidence to the contrary and are not typical of a patient's culture or religion. For example, a patient who believes that others are reading his thoughts. Okay, but a patient who thinks that they had God coming in their dreams and telling them to do some things, that could not be, that can't be like delusion, because you know that can happen in their religion and it's like a cultural thing, so that wouldn't be called a delusion. Okay. Types include ertonomanic, manic, grandiose, jealousy, uh, persecutory, somatic, mixed, and unspecified. Disorganized thought. Speech may be incoherent, so word salad or tangential or derailed. Lose associations. Okay. Uh, so hallucinations. It's perceptions in absence of external stimuli. For example, seeing a light that is not actually present. Contrast with misperceptions, for example, illusions or real external stimuli. Types include auditory, More commonly due to psychiatric illnesses, for example, schizophrenia, than neurologic disease. Whereas visual hallucinations are more commonly due to neurologic disease like dementia or delirium or drug intoxication that than any psychiatric illnesses. You have tactile hallucination. It's common in alcohol withdrawal and stimulant use, for example, cocaine crawlies, a type of delusional parasitosis. Olfactory hallucinations often occur as an aura of temporal lobe epilepsy, for example, burning rubber, and in brain tumors. Gustatory hallucinations, it's rare but seen in epilepsy. Hypnagogic occurs while going to sleep, so sometimes seen in narcolepsy. And hypnopompic occurs while waking from sleep, so get pumped in the morning. It's sometimes seen in narcolepsy. Okay. Contrast with illusions. Okay, so you need to know the difference between these two, right? So gogic is going to sleep, and pompic is waking up from sleep. We'll read about it in narcolepsy as well. Contrast with illusions, which are misperceptions of real external stimuli. For example, mistaking a shadow for a black cat. And mood disorders now. Okay. So it's characterized by an abnormal range of moods or internal emotional states and loss of control over them. Severity of moods causes distress and impairment in social and occupational functioning. Includes major depressive, bipolar, dysthymic, and cyclothymic disorders. Episodic superimposed psychotic features, so these are your delusions, hallucinations, disorganized speech, behavior. It may be present at any time during mood changes. Okay, so now we're going to talk about all the mood disorders. Okay, so schizophrenia spectrum disorders. Schizophrenia. Okay, those are a lot of notes I added, but I think it's just making it simple. Or okay, so schizophrenia is chronic illness causing profound functional impairment. Symptom categories include positive, negative, and cognitive. So positive symptoms are excessive or distorted functionings like hallucination, delusions, usual thought processes, disorganized speech, and bizarre behavior. Right. So these are all your positive ones. Then you have the negative ones. These are diminished functioning, for example, flat or blunted affect, or apathy. Apathy is like they don't care. So lack of interest, enthusiasm, or concern. And hedonia, that's inability to feel pleasure. Elogia, it's poverty of speech, and social withdrawal. Okay. Cognitive is symptoms are reduced ability to understand or make plans, diminished working memory, and inattention. I think I have that right now. Okay. Diagnosis requires more than two of the following active symptoms, including one or more from symptoms 1 and 3, right? So, two or more from this, as long as one or more are from these, right? So, delusion, hallucination, uh, disorganized speech. So, there it has to be one of these, and then it has to be two or more, right? So, then it could be from any of these two. So disorganized speech and negative symptoms. So that's what that is. Okay, so delusion, hallucination, often auditory or disorganized speech. And then you have disorganized or catatonic behavior and negative symptoms. Okay, so these are the defining features of schizo, and these can be seen in other mental illnesses or MDD as well. What's disorganized speech? It's people with disorganized speech might speak incoherent coherently, responds to questions with unrelated answers, says wow, illogical things or shift topics frequently. Signs of disorganized speech involve the following: loose associations, rapidly shifting between topics with no connection between topics. Okay, so that's disorganized speech. So symptoms onset is more than 6 months prior to diagnosis, require more than 1 month of active symptom, right? So schizophrenia, that's more than 6 months. Okay, and it has to have at least one or more month of active symptoms over the past 6 months, right? So active symptoms would be one of these. It's associated with altered dopaminergic activity, so it increases serotonergic activity and decrease in dendritic branching. Okay, so here we see schizophrenia. We see dopamine increases in schizophrenia, causing the positive stuff, right? And then we have serotonin that increases as well. Okay, that's from here, so I added that over there. Okay, and decrease in dendritic branches, ventriculomegaly on brain imaging. Lifetime prevalence is 1.5%, males more than females. It presents earlier in males, late teens to early 20s, than in females, so late 20s to early 30s. There's an increase in suicide risk. So it's young adults for males, and then uh, mid 20s to 30s for females. Heavy cannabis use in adolescence is associated with increased incidence and worsen course of psychotic, mood, and anxiety disorders. So, someone who smokes weed, they can end up with schizophrenia. Uh, you know, when they were younger and it was heavy smoking. Treatment is atypical antipsychotics, for example, risperidone or first line. Negative symptoms often persist after treatment despite resolution of positive symptoms. So negative symptoms persist often after treatment as well. So negative symptoms would be, all of these. Okay, cool. And then we have brief psychotic disorder. This is one or more positive symptoms. Okay, so remember, those are this. Lasting between 1 day and 1 month. Usually stress related. Okay, so, uh, it's less than 1 month. It doesn't go beyond 1 month. And then you have schizophreniform disorder. This is two or more symptoms lasting 1 to 6 months. Okay, of that. And symptoms are any of these. Okay, so that's schizophreniform. For it to be schizophrenia, it has to be two or more, and one of them has to be from these three, and the other one can be, from these three or these two. Then you have schizoaffective disorder. Okay. Okay. Schizoaffective disorder shares symptoms with both schizophrenia and mood disorders, so MDD or bipolar disorder. To differentiate from a mood disorder with psychotic features, patient must have more than 2 weeks of psychotic symptoms without a manic or depressive episode. Okay. Um, so schizoaffective disorder. This is a tough one to figure out because you have to be able to cross out all of these. You gotta cross out MDD, you gotta cross out psychosis and all that stuff, bipolar disorders as well. And after you've done all of that, then you can pick this one. So this is a tough one to pick, and it usually doesn't show up in options anyways, so it's okay. Uh, Delusional disorder, more than one delusions lasting more than 1 month. Okay, so one or more delusions lasting for more than 1 month, but without a mood disorder or other psychotic symptoms. Daily functioning, including socialization, may be impacted by the pathological fixed belief but is otherwise unaffected. Okay, so this is the delusion one, right? Well, more than 1 month. Okay, so this is the disorder for it. Okay, if it stays there for more than 1 month. Daily functioning, including socialization, may be impacted by pathological fixed belief but is otherwise unaffected, can be shared by individuals in close relationship. It's called folio, or something like that. Schizotypal personality disorder. So clustery personality disorder that also falls on the schizophrenia spectrum. It may include brief psychotic episodes like delusions that are less frequent and severe than in schizophrenia. Okay. Yeah, gotta know about that. And then you have manic uh, episode. So, manic episode, distinct period of abnormally and persistently elevated, expansive, or irritable mood, and increase in activity or energy. Diagnosis requires marked functional impairment with more than three of the following for more 1 or more week, or any duration if hospitalization is required. So, people with mania dig fast. For this, I made one as well. It's mnemonics. Okay, so mnemonics are more goal directed activity or moving without purpose or moving toes or tapping feet. Okay, so that's for M. A is for avoids focus on actual work. N for narcissistic. Uh, I for impulsive or discretion. C for can't stop talking or sleep. And S for so many ideas and thoughts going through their head. Okay, or you can do dig fast. Dig fast is D for destructibility, impulsivity, indiscretion that seeks pleasure without regard to consequences, right? Hedonistic, uh, grandiosity, inflated self-esteem, flight of ideas, racing thoughts, increased goal-directed activity or psychomotor, agitation, decreased need for sleep, and talkativeness or pressured speech, right? So manics, it's easier to remember from manic episode if you remember manics, but just by itself, when they present a scenario or in the vignette, it's gonna be pretty obvious that this person is having a manic episode. Then there's something called hypomanic episode. It's similar to a manic episode, except mood disturbance is not severe enough to cause marked impairment in social and or occupational functioning or to necessitate hospitalization. Okay. Abnormally increased activity or energy usually present. No psychotic features. Last 4 or more consecutive days. Okay. So if it's not that severe, it's going to be hypomanic. Bipolar disorder. So bipolar 1 and bipolar 2. So bipolar 1 is one or more manic episodes, with or without a hypomanic or depressive episode, may be separated by any length of time. And then bipolar 2 is a hypomanic and a depressive episode. No history of manic episodes though. Okay. Patient's mood and functioning usually normalizes between episodes. Use of antidepressants can destabilize mood. High suicide risk. Treatment is mood stabilizers, for example, lithium, valproate, carbamazepine, and lamotrigine. Atypical antipsychotics as well. Cyclothymic disorder, milder form of bipolar disorder, fluctuating between mild depressive and hypomanic symptoms. It must last 2 or more years, with symptoms present at least half of the time, with any remission lasting 2 or less than 2 months. Okay. With bipolar, it's again they'll have manic and depressive episode when they explain it, because otherwise it would be hard to diagnose it just from the question itself. Okay. Then we have major depressive disorder. It's recurrent episodes lasting more than 2 or more weeks, characterized by 5 or more of the 9 diagnostic symptoms, including depressed mood or anhedonia or irritability in children, or inability to feel pleasure. Right? Okay. So, major depressive disorder, don't worry about memorizing it, just know what it is, and you know, you'll be good with that. So, it will just make sense by itself. So, sleep disturbances will happen in depression, right? There will be decreased interest in pleasurable activity. There will be guilt or feeling of worthlessness, decrease in energy or concentration. These are the important ones you got to remember, that this is also, you know, happens in major depressive disorder. Then you have appetite or weight changes, psychomotor retardation or agitation, and suicidal ideation. That should be the easiest one to remember, right? So again, sleep disturbances, decrease in interest in pleasurable activities, guilt or feeling of worthlessness, decrease in energy, decrease in concentration, appetite, weight changes, psychomotor retardation or agitation, and suicidal ideation. Screen for previous manic or hypomanic episodes to rule out bipolar disorder, and that's important, because in the question stem they will give you that this person uh, you know bought a ticket and spontaneously made a trip abroad, and then came back, and then they were depressed for a while, and then they did something else that was spontaneous. That's bipolar disorder, right? But when they say nothing's been happening good in their life and they have been like this for a while, they don't have any history of going out on trips, or they'll explain that they didn't have anything that points towards manic episodes. So then you can safely assume it's MDD. Okay. Treatment is CBT and SSRIs, which are first line. Alternative includes SNRIs, mirtazapine, bupropion, electroconvulsive therapy, and ketamine. Responses to a ketamine, that's a NMDA one. Responses to a significant loss, for example, bereavement, natural disaster, disability, may resemble a depressive episode, and diagnosis of MDD is made if criteria are met. And the criteria is they gotta have 5 of these things happening. So they'll give you a long history for this one, right? And it has to last for 2 or more weeks. Okay, so you gotta remember these symptoms. You gotta remember the manic ones, and you also gotta remember the schizophrenia ones. Okay, so go over that. Major depressive disorder with psychotic features, MDD plus hallucinations or delusions. Okay, so if you have MDD plus any of these part of the symptoms over here, uh, then you can say that it's MDD with psychotic features. And for it to be psychotic, you gotta have hallucinations or delusions. Psychotic features are typically mood congruent. For example, depressive themes of inadequacy, guilt, punishment, nihilism, disease, or death, and occur only in the context of major depressive episode versus schizoaffective disorder. Remember, schizoaffective, and to be effectively schizophrenic, uh, you gotta have it more than 2 weeks of psychotic symptoms without a manic or depressive episode. Okay. Uh, okay. So, treatment is antidepressant with atypical antipsychotics and ECT. Uh, this is all you have to remember, if nothing else, for this one. Persistent depressive disorder, also called dysthymia, often milder than MDD. More than two depressive symptoms lasting more than 2 years. 2 or more years, okay. Two or more symptoms. So also called dysthymia. Look that up. Persistent mild depression. Okay. So persistent depressive disorder. If it's more than two depressive, any of these two symptoms lasting more than 2 years, it's called persistent depressive disorder. Okay. So in adults it's two or more, but in children it's 1 or more years in children, right? With any remission lasting less than 2 or 2 months. Major depressive disorder with seasonal pattern, so it's formally called seasonal affective disorder. Major depressive episodes occurring only during particular season, and it's usually winter, in 2 or more consecutive years, and in most years across a lifetime. Atypical symptoms common. Treatment is standard MDD therapies and uh, light temperature. Okay, so SSRIs, selective serotonin, and selective norepinephrine receptor inhibitors. Okay, so depression with atypical features. These are characterized by mood reactivity, transient improvement in response to a positive event, hypersomnia, hyperphagia, lead-in paralysis, heavy feeling in arms and legs. That's what it means. Long-standing interpersonal rejection, sensitivity. Most common subtype of depression, and treatment is CBT and SSRIs are first line. MAO inhibitors, right? So MAO, it's like mow the line, so it's the ones with line in it. So selegiline and repa, repagiline or something like that. So MAO inhibitors are effective but not first line because of their risk profile. Okay. Peripartum mood disturbances. Onset during pregnancy or within 4 weeks of delivery. Increased risk with history of mood disorders. Okay. So if they get pregnant and they have a history of this, then chances are they'll have postpartum or peripartum mood disturbances. Okay. Postpartum blues, it's 50 to 85% incidence rate. It's characterized by depressed affect, tearfulness, and fatigue starting 2 to 3 days after delivery. Usually resolves within 2 weeks. Treatment is supportive. Follow up to assess for possible MDD with peripartum onset. Okay, so 2 to 3 days after delivery, and it resolves within 2 weeks. So if you have something that's longer than 2 weeks, it's gonna be something else. Okay. MDD with peripartum onset, that's 10 to 15% incidence rate, formerly called postpartum depression. Yeah, this one. It meets MDD criteria with onset either during pregnancy or within 4 weeks after delivery. Treatment is CBT and SSRIs, which are first line. Postpartum psychosis, 0.1 to 0.2% incidence rate, characterized by mood congruent delusions, hallucinations, and thoughts of harming the baby or self. Risk factors include uh, first pregnancy, family history, bipolar disorder, psychotic disorder, recurrent, medication change. Treatment is hospitalization and initiation of atypical antipsychotics. If insufficient, ECT may be used. I got zoned out in this one. Let me read that again. Yes, it does. 0.1 and 0.2% incidence rate, characterized by mood congruent delusions, hallucinations, and thoughts of harming the baby or self. For this one, this is how they word it in the scenario itself: harming the baby or self, right? This one doesn't apply to miscarriages, but these ones do. You can have it in this. But also you gotta remember it also overlaps with grief disorder, right? So if it lasts for 1 month, it's still okay. So if it goes about 2 and it lasts for 1 month, that's still grief. Uh, okay, but if it lasts more than that, like I think you can give it like 6 months, and then after that you can go into MDD and all that stuff. Okay, so this is how they will word it for psychosis. Okay. Risk factors include first pregnancy, family history, bipolar disorder, psychotic disorders, recent medication changes, hospitalization and initiation of atypical psychotic antipsychotics. If insufficient, ECT may be used. Okay. Normally, when they ask you questions, they will feed you the answers in the question itself. So you just need to learn how to read it and how to, trim off the fat from the question so you only look at the meat of it, which is gonna, point towards the answer. And they don't really try to confuse you if it's something, very similar. They won't do that because they know it's hard to do that. But then, if it's something like manic and depressive disorder, then you should know the difference between, MDD and bipolar or something like that. So those are the types of things that they ask for you to differ. Okay. Electroconvulsive therapy, rapid acting method to treat refractory depression with psychotic symptoms, catatonia, and acute suicidality. Induces tonic-clonic seizures under anesthesia and neuromuscular blockade. Adverse effects include disorientation, headache, partial anterograde retrograde amnesia, usually resolving in 6 months. No absolute contraindication, and it's safe in pregnant individuals and older adults. So there'll be a question about this. They'll tell you that the patient was there was an appointment for ECT, and then it turned out she's pregnant. What should the next step be? You just continue with the treatment because it's safe in pregnant individuals and older adults. Okay. Uh, there are no absolute contraindications about it, so you can use it in all of these. Okay. Risk factors for suicide death. This is important, especially the first three. So, sex, and it's more common in male. Age, young adult or other older adults. Not the first three. So that too, and access to firearm. We'll read about that in this, I guess. So, sex, male, age, young adult or older adults. Depression, previous attempt is the highest risk factor. Okay, so this is the highest risk factor. Ethanol or drug use, rational thinking loss, psychosis, sickness, medical illness, organized plan, no spouse or other social support, and stated future intent. Okay. So there will be a question about this person is at risk of suicide. What is the highest risk factor in this person's life? And they'll, give a whole scenario about the person's life, and then they'll be depressed. They'll have they're drinking alcohol. They're male, young adult. They'll give you all of these, and then they'll ask you what's the highest, or what's the highest risk factor out of in all of these. So previous attempt is the highest factor. Okay. Said person are more likely to die from suicide. More common method in US is firearms. Access to guns increases risk of suicide death. Okay, so women try more often and men die more often. Okay, so they attempt more and here they complete more. Other risk factors include recent psychiatric hospitalization and family history of suicide death. Protective factors include effective care for comorbidities, medical, familial, or community connectedness, cultural religious belief, encouraging self preservation, and strong possible solving skills. Okay. So they'll ask, like, what's the highest risk of completed suicide for men, right? It's access to firearm. That's the highest. That would be the answer for that. But if they don't tell you that anything about that, then it's going to be this one, previous attempt, and it's going to be between these two that you get confused. So you'll figure that out in the questions. Anxiety disorders, inappropriate experiences of fear, worry, and their physical manifestations incongruent with the magnitude of the stressors. Symptoms are not attributable to another medical condition, for example, psychiatric disorder, hyperthyroidism, or substance use. It includes panic disorder, phobias, generalized anxiety disorder, and selective mutism. Okay. Yeah, anxiety, that's an important topic too. So, anxiety, and there's panic disorder, right? So, it's recurrent panic attacks involving intense fear and discomfort with or without a known trigger. Okay. So with anxiety disorder, they just explained it, but the things that you need to know about are social anxiety disorder, that and generalized anxiety disorder. Those two are the ones you should know about regarding anxiety and what the difference is between anxiety and panic disorder. Okay. So in panic disorder, it's recurrent panic attacks involving intense fear and discomfort with or without a known trigger. Uh, Attacks typically peak in 10 minutes. Okay, and that's important. It could be 10 to 15 minutes with four or more of the following. So they'll have palpitations, paresthesia, depersonalization or derealization, and abdominal pain, nausea, intense fear of dying, intense fear of losing control, lightheadedness, chest pain, chills, choking, sweating, shaking, shortness of breath. Okay, so normally these will be covered by vitals, the shortness of breath, the palpitation, right? Maybe even sweating. Okay, and then two more of these they'll give you, and then you should be able to figure out that this person's having panic, because they'll tell you that they were feeling these symptoms before they came in, but like within 10 to 15 minutes the person seemed normal by the time they started doing examinations of him, right? So that's a panic disorder. Strong genetic component, so usually they fear of dying, right? So it's you should pay attention to that. Strong genetic component, increased risk of suicide. Okay, diagnosis require attack followed by one or more of the following. persistent concern of additional attacks. So they'll be, coming in because of their concern of this. So that's that persistent concern of additional attack. Worrying about consequences of attack. So, you know, leaving behind someone or something like that, that would be a consequence. No, not really. It's just, I guess, them dying. Their fear of dying, that's the consequence of the attack. And behavioral change related to attacks. Okay, so it could be like whenever they go, I don't know, how would they change it? They avoid going or doing certain things that they think would trigger uh, a panic attack, right? So that's a behavioral change. Symptoms are systemic manifestations of fear. Treatment is CBT, SSRIs, and venlafaxine, which are first line. Benzodiazepine, occasionally used in acute setting. Okay, so that's an important one, but normally it's these. Phobias: severe, persistent, more than six or more months. Fear of anxiety due to presence of anticipation of a specific object or situation. Person often recognizes fear as excessive. Okay. Treatment is CBT and exposure therapy. So that's important here. They recognize that it's excessive, right? And here they do not recognize that. Okay. Fear or anxiety due to presence of anticipation of a specific object or situation. So here, that we have two types of phobias or subtypes. One is social anxiety disorder and another is agoraphobia. Okay, so social anxiety disorder, it's exaggerated feeling of embarrassment in social situations, for example public speaking, using public restrooms. Okay. Treatment is CBT and SSRIs and venlafaxine. For performance type, for example, anxiety restricted to public speaking, you can use beta blockers or benzodiazepines. Okay. And then agoraphobia is irrational fear, anxiety, and/or avoidance while facing an anticipation. So this one is you gotta watch out for this and this, right? Because it's similar. But how in agoraphobia, it's due to like public transportation or closed spaces or something like that. Okay. And whereas here, it's because of maybe their friend who's the same age suffered a stroke, so they feel like they're about to have a stroke, so they panic and all that stuff. Okay. Whereas here, it's gonna be complete different type of scenario. Irrational fear, anxiety, and/or avoidance while facing an or anticipating two or more of the specific situation. For example, public transportation, open or closed spaces, lines or crowds, being outside of home alone. Okay. Symptoms stem from the concern that help or escape may be unavailable, and that's where it's coming from. That next time they have an episode and they're on a bus, they won't be able to get off and get help right away. Okay. It's associated with panic disorder. Okay. So they'll have panic. They'll panic and then they're on the bus. So their panic is because they're on the bus and it's closed and they won't get help. That's what they believe, right? Or they're in a closed space where they won't, even if they collapse, no one's gonna know and they won't get help because of that. Something like that. Okay, agoraphobia, let's look it up. Extreme or irrational fear of entering open or crowded space, of leaving one's own home, or of being in place from which escape is difficult. Okay. Generalized anxiety disorder. This one is more mature in the sense that they know about it and they're concerned about what it's doing to them, but they can't help it. So it's excessive anxiety and worry about different aspects of daily life, like work or school or children. And that's what the scenario will be about. That this person is worried they won't be able to finish the work in due in before the deadline. They gotta bring the kids back home from school, and you know, something like that. Uh, and this is going to be for most days of the 6 or more months. It's associated with three or more of the following for adults and one or more of for the kids. So it could be difficult in concentrating, restlessness, irritability, muscle tension, fatigue, so low energy, sleep disturbances, anxiety over crimes. Okay. Don't need to remember that. Just it makes sense by itself. So someone who has anxiety, they will have difficulty in concentrating. They'll be restless and irritable, right? Their muscles will be tensed up. Someone who's who has anxiety, right? And soon enough they'll be tired from all the muscle tension, and they can't sleep, right? Because they have anxiety. So how can you sleep when you have anxiety? Okay, so learn the difference between anxiety and panic disorder, because then it will be easier to differentiate between them. But for anxiety, I've seen that most of the questions are similar to each other, whereas it's different from panic disorder. But it does get confusing between that, agoraphobia, and generalized disorder. The giveaway for this one is that they're worried for more than one thing, and it's not about them. Okay, it's going to be something about work or kids or school, something like that, but it's not about themselves. Whereas panic, it's because of themselves. They're worried about themselves here, and it's going to be one or more of these things. Whereas agoraphobia, it's about them being in closed space or crowded space where they're worried they won't get help. Okay. Obsessive compulsive disorder, it's obsessions, recurring intrusive thoughts, feelings, or sensations that cause severe distress, relieved in part by compulsion, performance of repetitive, often time consuming actions, ego dystonic, behavior inconsistent with one's belief and attitudes, versus obsessive compulsive personality disorder and egocentric tonic. It's associated with Tourette syndrome. Treatment is CBT and SSRIs. Clomipirmin and venlafaxine are second line. Okay, so this, someone who goes out, they gotta flip the switch 3 times, or uh, they avoid the cracks on the floor. Uh, Whenever they look in the mirror and see something, they gotta clean it right away. They fix the items on a table in a particular manner. All of these things are obsessive compulsive disorder, right? You gotta be able to differentiate OCD with the spectrum for autism, okay? Because some of the things overlap there as well. Um, but that one is, they'll give you other stuff for autism, but you need to be able to figure it out from that. Okay. Then there's also body dysmorphic disorder. So preoccupation with minor or imagined defects in appearance. So uh, this thing came up recently when there was a rise in plastic surgery. Um, okay, so causes significant emotional distress and repetitive appearance related behavior. For example, mirror checking, excessive grooming. Uh, Common in eating disorder, and treatment is CBT. So you know about that guy who wants to look like Ken doll, right? He has plastic all over his face and arms and legs and butt and abs as well. So they gave a scenario of that, and they asked you what it is. So even though he's pretending that he wants to be like that, it's because he doesn't think his own body is, good enough. So it's called body dysmorphic disorder like that. Okay, trichotillomania, compulsively pulling out one's hair, causes significant distress and persists despite attempts to stop. Okay. It presents with area of thinning hair or baldness on any area of the body, most commonly the scalp. Okay. Remaining hair shafts are of different length versus alopecia. Incidence highest in childhood, but spans all ages. Treatment is psychotherapy. Yeah, that's. They'll give you a photo of this and ask you, what is this? Is it alopecia? Is it this? So you need to be able to figure out which one it is, right? You need to know what alopecia looks like, or male pattern baldness or female pattern baldness, and then this, and certain other things like deficiency in DHT or something they'll give you. So trichotillomania. Okay. For this one, it's gonna be different hair shafts for all over the thing. Okay. Let's look at a few more photos of these. Okay. Nope. Okay. Not good enough for that. So that's the Wikipedia one. Yeah. That. That as well. You see how there's still hair growing over there, whereas in alopecia you wouldn't have those growing, right? That's not trichotillomania. I think that's just someone, shaving their hair. I think. But okay, so this is alopecia. You don't have any strand of hair in that area, right? And that's the difference between this and trichotillomania. Okay. So alopecia areata, you need to know about that one. Uh, she's self-proclaimed victim of alopecia. Apparently, she said that, but you see hair shafts on her scalp, so it doesn't seem like it's alopecia. But anyways, in alopecia you don't see hair strands, whereas in the other one you see hair strands, right? And that's how you differentiate between those. 9 minutes. Okay, I think we can finish. So trauma and stress related disorder, adjustment disorder. That's emotional or behavioral symptoms. For example, anxiety and outbursts that occur within 3 months of an identifiable psychosocial stressor. For example, divorce and illness lasting less than 6 months. Once the stressor has ended. Okay. So these things happening that occur within 3 months of an identifiable psychosocial stressor. Okay, and they last less than 6 months. Once the stressor has ended. Okay. Symptoms do not meet criteria for another psychiatric illness. If symptoms persist, so for something like this, they'll give you a straightforward scenario that won't confuse you, because if they start confusing you, then you gotta do differentials with the other stuff, and chances are you will pick something else. So to avoid that, they'll give you a straightforward thing. It's gonna be that person got divorced, right? And or they moved to a new place and it's been over 6 months. So what is it called? Why are they? What is it? So if it's less than 6 months, it's adjustment disorder, and if it's more than 6 months, it's generalized anxiety. Okay. Symptoms do not meet criteria for another psychiatric illness. If symptoms persist more than 6 months after stressor ends, reevaluate for other explanations. For example, MDD or generalized this. Usually it's this one, because this one it's pretty easy to figure out anyways. and you would need a long scenario for that. You need a long scenario for this because you need 5 out of 9 symptoms for this, so they gotta give you all 5 of them at least. So if it's a small scenario, it's gonna be this one. Treatment CBT is first line. Antidepressants and anxiolytic may be considered. And post-traumatic stress disorder or PTSD, it's experiencing, witnessing, or discovering that a loved one has experienced a life-threatening situation, for example, serious injury or sexual assault. And then there is a persistent hyperarousal, avoidance of associated stimuli, intrusive re-experiencing of the event, for example, nightmares and flashbacks, changes in cognition or mood, for example, fear, horror, or distress. Having PTSD is hard, and that's the acronym. Disturbance lasts more than 1 month with significant distress or impaired functioning. And this is important, so you need to remember the timeline for this. So disturbances that last more than 1 month with significant distress or impaired functioning. Okay, so if it's less than 1 month, it's not called PTSD, it's just, them dealing with it. But if it lasts more than 1 month and, it's gonna be about some soldier who came back from war and then, certain things triggered them to, relive their stressful stuff. Okay, so disturbance lasts more than 1 month with significant distress or impaired functioning. Treatment in CBT, SSRIs, and venlafaxine are first line. Prazosin can reduce nightmares. Acute stress disorder lasts between 3 days and 1 month. Treatment is CBT. Pharmacotherapy is usually not indicated. Okay, so acute stress disorder, it lasts from 3 days to a month, but if it's more than 1 month, it's going to be this. Okay, so you got to differentiate between these two, and that's from this. Okay. So we looked at these as we were doing it anyways, but the ones we didn't look at is this one and the generalized one. Okay, now we looked at this one. Narcolepsy, we didn't look at it because we haven't done it yet. So let's look at the one we haven't looked at yet. So manic or symptoms of bipolar, it has to be more than 1 week. And then for major depressive, it's more than 2 weeks. Dysthymic and cyclothymic, it's more than 2 years. And anxiety, panic more than 1 year, 1 month. Acute stress is less than a month, and post-traumatic is more than 1 month. Adjustment is less than 6 months. Generalized anxiety is more than 6 months, and phobias. Adjustment, it's always going to be about either divorce or them moving away to a new place. And it hasn't been 6 months yet, so it's just adjustment disorder. Okay, that's it for that. Let's take a break. Personality disorders. Inflexible, maladaptive, and rigidly pervasive patterns of behavior causing subjective distress and or impaired functioning. So person is usually not aware of the problem. So egosyntonic. Usually presents by early adulthood. It contrasts with personality traits, non-pathologic enduring pattern of perception and behavior. There are 3 clusters. Cluster A, odd and eccentric. Remember as weird. Inability to develop meaningful social relationship. No psychosis. Genetic association with schizophrenia. Okay, so these are the weird and odd ones. Cluster B is dramatic, emotional, and or erratic. So remember as wild. Okay. Genetic association with mood disorders and substance abuse. And then you have cluster C, anxious or fearful. Remember as worried. Okay. Genetic association with anxiety disorders. Okay. So Schizotypal, we read that up there. Schizotypal personality disorder. It was clustery personality disorder that also falls on the schizophrenia spectrum. May include brief psychotic episodes, for example, delusions. They are less frequent and severe than in schizophrenia. Okay, so schizotypal, it's eccentric appearance, odd beliefs, or magical thinking, interpersonal awkwardness. Okay, so this one is the one with the crystal ball, or fortune uh, reader and all that stuff, right? So, darling, let me read your fortune, right? I believe in ghosts and I don't know what that is, fairies and stuff like that. Okay, so pronounce schizotype O-typal for O odd type thoughts. Okay, and paranoid is pervasive distrust, accusatory suspiciousness, hypervigilance, and a profoundly cynical view of the world. And schizoid, they prefer social withdrawal and solitary activities versus avoidant. That's type C. Okay, so they prefer to be alone and do things by themselves. Okay, limited emotional expression, indifferent to others' opinion, and aloof. Okay, so we did those three. So paranoid, schizoid, and schizotypal. Okay. So odd thinking behavior or eccentric behavior, that's paranoid, schizoid, and schizotypal. Know the difference between the three. Okay. So schizoid is just, think of someone with the zoid, so it sounds like a shape, right? Schizoid. So just, I don't know, there's a person, right? And draw schizoid shape around it. So it's probably something like, schizoid. So that's, blocking them from everyone else. There's there are other people out here, so they don't talk to them. They prefer to be alone in their own, schizoid or area, right? So isolated from people. So prefer social withdrawal and so solitary activities, limited emotional expression, indifferent to others' opinion, right? They're aloof, and what aloof means is not friendly or forthcoming, cool and distant, right? They were courteous but faintly aloof. So probably like, no, Robert Pattinson from Twilight. Okay. Schizotypal. Again, that's they believe in all the magic stuff and crystal balls, fortune reader, and all that stuff. Paranoid, they just accuse and are suspicious. On to cluster B. Okay, so cluster B, antisocial. It's antisocial, borderline, histrionic, and narcissistic. Okay, so antisocial personality, disregard for the right of others with lack of remorse, involves criminality, impulsivity, hostility, and manipulation. Sociopath, male more than female, so it occurs more in males than female. Okay, must be more than 18 years old with evidence of conduct disorder onset before age 15, right? And conduct disorder, it has to be less than 18-year-old, and after 18, if it continues, it's called antisocial personality disorder, right? So if patient is less than 18, a diagnosis is conduct disorder. Okay, so disregard of right of the others, they are hostile towards authoritative figures. Okay, so it involves criminality, impulsivity, and hostility. See, antisocial, disregard for rule, disregard for the right of others, deceitful, manipulation, and aggressiveness. Okay. Uh, so not very social of them for doing those things. Borderline, unstable mood and interpersonal relationship, fear of abandonment, impulsivity, self mutilation, suicidability or suicidality, uh, deeply unhappy or depressed and likely to commit suicide. Okay. Sense of emotional emptiness, right? So borderline. Uh, and female more than it's seen more in female than male. Splitting is a major defense mechanism. That is important. If they give you a scenario with splitting, uh, and they ask you in the option what it is out of which clusters, it's gonna be borderline because splitting doesn't occur in any other personality. It's only in borderline, and it helps because there's a border between good people and bad people for them, and also they're always on the border or on the edge, uh, right? Because they're unstable mood, and they're right at the edge of committing suicide, stuff like that. Okay, they cut themselves. Okay, treatment is dialectical behavior therapy. Histrionic, so borderline, intense emotion, fears of abandonment. That's an important one. Unstable relationships and identity issues. Uh, yeah, so that's a big one too. That's like a buzzword for borderline as well. They don't want to cross the border by themselves. Uh, Maybe that will help. Okay. Histrionic, attention seeking, dramatic speech, and emotional expression, shallow and labile emotions, sexually provocative, may use physical appearance to draw attention, flamboyant. Okay, that's an easy one. So, histrionic person, dramatic behavior, inappropriate sexual or provocative behavior, need to be the center of attention. Right? Like to be the center of attention. Okay, and then narcissistic. So that's sort of like that as well, right? Uh, it feeds into their narcissism. Grandiosity, sense of entitlement, lacks of empathy, and requires excessive admiration. Often demands the best and reacts to criticism with rage and or defensiveness. Must be the best. Now, fragile self-esteem, often envious of others. There's this guy who's like a diagnosed narcissist, and he goes around talking about his condition. So he's making money while feeding his ego or his narcissism, right? Because he talks about it while everyone else listens to him, takes notes, and he's always it's basically grandiosity. That's what it is, and sense of entitlement it gives him for doing that. So he's making money off of his own condition, and it's feeding it. So that's pretty interesting. Okay, so sign and symptoms: like to be the center of attention. Sufferers tend to feel an extreme emptiness, so that would be like the borderline. Sufferers tend to have frequent self-harm, that's also borderline. Uh, People practice of manipulation for their personal gain, that's antisocial, right? Um, this is histrionic. Right? People behave in a very arrogant way, that's almost all of them, except for borderline. And like to be the center of attention in social situations. Right? So that's histrionic as well. Isn't 1 and 6 the same thing? Oh, but center of attention in social situations. So by causing drama and stuff. Okay. And then there's cluster C, avoidant. So this one is different from schizoid. Because in schizoid, they prefer to do that. In avoidant, it's hypersensitivity to rejection and criticism. It's the fear of all of these things that is keeping them from other stuff. So it's not that they prefer it, but they're hypersensitive to rejection and criticism, socially inhibited, uh, timid, cowardly, feeling of inadequacy, desires relationships with others versus schizoid. Right, so they want to be with someone, but they're just scared of all of these things. So they're part of cluster C. Okay. Okay. So avoidant. I want. I won't go. No one likes me. Okay. Then there's obsessive compulsive. It's preoccupation with other, perfectionism, and control. So obsessive compulsive. Egocentric. Behavior consistent with one's own beliefs and attitude versus OCD. Okay. Obsessive compulsive. So that's not what the list says. Right. And then dependent is excessive need for support. So they're clingy. That's different from fear of abandonment. Okay, that's a different one. So you gotta be able to differentiate those two. Submissive, low self confidence. Patient often gets stuck in abusive relationship. Okay. So, what do you think I should do? Okay, sure. Yes, don't leave. And then there was this antisocial, in jail, emotional borderline. I love you. I hate you. Both of those, right? That's different than dependent, right? So you can differentiate that way. That would help you. Uh, Histrionic, attention, me in the spotlight. And then there is narcissistic, PhD of bullshit, PhD of bullshit. Where'd it go? You're beneath me. Okay, so that should help you with that. On to malingering. Malingering are symptoms of intentional. Motivation is intentional as well. So intention, everything is intentional. It's not, organic. So symptoms are intentional. Motivation is intentional. The patient consciously fakes or profoundly exaggerates or claims to have a disorder in order to attain a specific secondary gain or external gain. For example, avoiding work or obtaining compensation. Poor compliance with treatment or follow up of diagnostic tests. Complaints cease after gain versus fictitious disorder. Okay. So after they get their what they were after, all the symptoms go away. Versus fictitious disorder. So fictitious disorder is symptoms are intentional, but motivation is unconscious. Okay, so patient consciously creates physical and or psychological symptoms in order to assume sick role. Okay, so that's important. Here, everything is intentional, whereas in fictitious, motivation is unconscious. Okay, so sick role and to get medical attention and sympathy. So that's the primary internal gain. So there are two types of fictitious disorder. There's imposed on self and imposed on another, also known as Munchausen syndrome. So fictitious disorder imposed on self, formerly called Munchausen syndrome. Okay, so this one's Munchausen syndrome by proxy. Formerly called Munchausen syndrome. It's chronic fictitious disorder with predominantly physical signs and symptoms, characterized by uh, history of multiple hospital admissions, and willingness to undergo invasive procedures, more common in females and healthcare workers. Okay, so even though they did all the tests and all that stuff, like they did the blood work and nothing showed up, they did the x-ray, nothing showed up, but then they still are like, no, I have this, you need to check it out, right? And they're always willing to go under extreme testing and lab work and all that stuff, and they're very compliant and all that. So that's Munchausen syndrome, and you can imagine why it's more common in female healthcare workers, right? Me just reading these stuff, I feel like I have half of these things happening to me while I'm reading it, right? So that's Munchausen syndrome, and then there's fictitious disorder imposed on another. Okay, over here, uh, it's formally called Munchausen syndrome by proxy. Illness in an individual being cared for, most often a child, also seen in disabled or older adults, is directly caused, for example, physically harming a child or fabricated, for example, lying about a child's symptom by the caregiver. Form of child or elder abuse. There's a story about this. It was about a mother who brought the child uh, to the hospital, and the child had severe, uh, serum sodium levels. Okay, so the doctor were thinking, okay, how is this even possible? Because it's not possible to have sodium in the body coming naturally, like developing it naturally, right? It has to come from exogenous source. So then uh, they waited it out, and then kept it in the hospital. Then after it was normal level, they discharged the child, and then like a week later the mother comes back with it, and the mother's all worried, and she's compliant to do all the testing and everything. And then they did that, and then again, the levels dropped after a few days, and then they got discharged. Then the next time she came in again, they did everything, they checked, and then this time they let the child stay there for a longer time. And what they noticed was that the levels started rising again. Okay, so the doctors actually then, you know, without asking, I think they went to the house to check it out without permission, or they asked the husband for the permission because he wasn't aware why this was happening. And what they found was like a bunch of table salt in the bathroom. So the mother was feeding table salt to the child, so she would get attention for all this. And yeah, that's the one that stuck with me. So uh, yeah, so they were testing for tumors and all this stuff, but nothing came positive. And then when they went to the bathroom of the lady, and the reason it was rising again in the hospital is because she was sneaking in some salt and then feeding it to the child. Okay, so form of child and elder abuse, Munchausen syndrome by proxy. Somatic symptoms and related disorders. Symptoms are unconscious, motivation is unconscious as well. Okay, so you will be having you will need to like be able to differentiate between all of these because they're similar. Okay, I think there's a chart for this. I'm not sure. Let me check. Yeah, so this chart should help. Okay, so in malingering, there is an external gain, and there's it's symptoms are deliberate. There's no psychiatric disorder, or and they don't really agree to procedures. Okay, they get very defensive when they're like, "No, why don't you just believe me? I have this. Just give me this." You know. And fictitious, we just read, the gain is sick role, so they get sympathy and all that stuff. uh, and it is deliberate, it is psychiatric disorder, and they will agree to all the procedures. In somatization, uh, they don't have gain, they don't do it deliberately, but it is psychiatric disorder, and they do agree to all the procedures. And uh, majority of the time, females are, uh, victims of this by doctors because they don't believe them. Uh, that does happen. Okay, so somatic symptom and related disorders. Symptoms are unconscious, motivation is unconscious. Category of disorders characterized by physical symptoms causing significant distress and impairment. Symptoms are not intentionally produced or feigned. Okay. Uh, no, actually, wait, I said it wrong. Doctor think, doctors think that it's nothing because they can't find anything, but it turns out that it's somatization. It's because it's one of these things. Conversion, I think. We'll read about it. I think I'm speaking too soon. Symptoms are not intentionally produced or feigned, right? So that. Somatic symptom disorder. It's one or more bodily complaints, for example, abdominal pain and fatigue, lasting months to years, associated with excessive persistent thoughts and anxiety about symptoms, may co occur with medical illness. Treatment is regular office visits with the same physician in combination with psychotherapy. Yes, that. And the bodily pain, so like abdominal pain or fatigue. Okay. Uh, yeah. Conversion disorder. It's also called functional neurologic symptom disorder. This is a tough one because um, you'll be confused between somatic and this basically. Because this one happens because of something causing, like a acute stressor that causes it. Okay. So unexplained loss of sensory or motor function, so paralysis, blindness, or mutism, often following an acute stressor. Patient may be aware of but indifferent towards symptoms. So labile indifference, more common in females. So this is the one that's more common in females. Okay, I thought it was that one. It's this one. Adolescents and young adults. Okay, and illness anxiety disorder. This one's okay. So when you're doing questions and you come across questions for these, make notes of these. It does help if you make notes. Illness, anxiety disorder, preoccupation with acquiring or having a serious illness, often despite medical evaluation and reassurance. Minimal to no somatic symptoms. Okay, so it's preoccupation with acquiring or having a serious illness, often despite medical evaluation and reassurance. Okay, so they did all the lab tests and everything, and they've been told that you don't have anything, you're okay, you're fine, good to go. But they don't believe them, so they continue, approaching other doctors or reading on what they think they have and all that stuff, and going on forums and stuff like that. Okay. So yeah, this chart is helpful, and this is also a chart. So malignant versus fictitious versus somatic. So that symptoms and motivation. So in malingering, the symptoms and motivation both are intentional. And fictitious, symptoms are intentional, but motivation is just sympathy or something like that. It's unconscious. They don't want to admit to it, so it's unconscious. Somatic symptom disorders, it's unconscious symptoms, and motivation is also unconscious. Conversion, it's something mental converting into something physical. Okay, and somatic, it's something physical uh, that can't be understood mentally. Okay, And illness, anxiety, there's nothing physical that they can understand mentally. Okay. Eating disorder, most common in young women. Anorexia nervosa, intense fear of weight gain, overvaluation of thinness and body image distortion, leading to caloric uh, restriction and severe weight loss, resulting in inappropriately low body weight. BMI less than 18.5 for adults. May present with hypothyroidism, amenorrhea, osteoporosis, and Lenugo. Okay, for this one, if they give you BMI that's less than 18.5, do not look at anything else. It's going to be anorexia nervosa. Okay, even if they eat a lot and then puke out or whatever, don't go for the bulimia one because you're seeing that BMI is less than this, so it's binge eating and purging type. So that happens in anorexia as well. Okay, so anorexia has three types: binge eating and purging type. Recurring purging behavior, for example, laxative or diuretic abuse, self induced vomiting, or binge eating over the last 3 months. Okay, so binge eating over the last 3 months does occur, right, in anorexia nervosa, and that's the one that will confuse you. So normally you would think that they avoid eating and they're always on diet or something like that, but there's a type of anorexia where there is binge eating over the last 3 months or something like that. Okay, and then they'll go into purging behavior for the next 3 months or something. Restrictive type, its primary disordered behaviors include dieting, fasting, and or over exercising. No recurring purging behavior or binge eating over the last 3 months. Okay, so in restricting type, that's normally what we think of when we are thinking of anorexia nervosa. So it's primary disordered behavior including dieting, fasting, and or over exercising. There is no reoccurring purging behavior or binge eating over the last 3 months. And then there is refeeding syndrome. So often occurs in significantly malnourished patients with sudden increase in caloric intake. So they have increase in insulin, which causes decrease in phosphate, potassium, and magnesium, causing cardiac complications, rhabdomyolysis, and seizures. Treatment are nutritional rehabilitation, psychotherapy, and olanzapine. Okay. Then we have bulimia nervosa. So for these, BMI won't be lower than 18.5. Okay, it will be somewhere in like 2021, I guess. Okay, so uh, bulimia nervosa, it's recurring episodes of binge eating with compensatory purging behavior, at least weekly over the last 3 months. Okay, so this happens weekly, whereas this one occurs for 3 months at least. Okay, BMI often normal or slightly overweight versus anorexia. So that's how you differentiate between the two. Associated with parotid gland hypertrophy. Uh, so this one is buzzword for bulimia. May see increase in serum amylase, animal erosion, Mallory-Weiss syndrome, right? That's laceration in the esophagus, or laceration type of lesions. Electrolyte disturbances, for example, decrease in potassium and chloride, metabolic alkalosis, dorsal hand calluses from induced vomiting, the Russell sign. So Russell sign is also a buzzword actually. This is the buzzword because these things I guess can happen in the purging type as well. But if you start seeing Russell signs, it's a buzzword for bulimia. And you gotta make sure that you see this. And sometimes they just tell you they're, um, obsessed with their, fat areas of their body. These are Russell signs. It's from trying to puke, and when the stomach acid comes up, uh, it gets into touching this, and then this get affected because of it. Okay. And that's a sign for bulimia. Treatment: psychotherapy, nutritional rehabilitation, antidepressants, for example, SSRIs. Bupropion is contraindicated due to seizure risk. Okay, so sometimes they give you the BMI, sometimes they don't. So you need to be able to do it without it as well. Differentiate between the two. Uh, Other times they'll give you BMI, but then they'll ask you which one of the anorexia is it, and then they'll give you other ones as well in the options. Uh, Binge eating disorder. So recurring episodes of binge eating without purging behavior, at least weekly over the last 3 months. There's increased diabetes risk, most common eating disorder in adults. Treatment is psychotherapy, first line SSRI, and lisdexamfetamine. Okay. Pica syndrome. They eat things of no substance value or nutrition value. So recurring episode of eating non-food substance, for example, ice, dirt, hair, paint chips. Okay, and you gotta remember ice, because the other stuff, that's non-food substance, but ice is also non-food substance. Okay, over more than 1 month that are not culturally or developmentally recognized as normal. May provide temporary emotional relief, common in children and during pregnancy. So this is usually happening because of iron deficiency. Okay, so if someone's doing that, check their iron. That's usually the cause of this, and that happens in pregnancy as well as in children. Associated with malnutrition, iron deficiency anemia, developmental disabilities, and emotional trauma. Treatment is psychotherapy and nutritional rehabilitation, first line, and then SSRIs are the second line. There's gender dysphoria. This is significant incongruence between one's gender identity and one's gender assigned at birth. Okay, lasting more than 6 months and leading to persistent distress. Individuals experience marked discomfort with their assigned gender, which interferes with social, academic, and other areas of function. Individuals may pursue multiple domains of gender affirmation, including social, legal, and medical. Uh, yeah. So, and then there's transgender. Any individual who transiently or persistently experiences incongruence between their gender identity and their gender assigned at birth. Some individuals who are transgender will experience gender dysphoria. Non-conformity to one's assigned gender itself is not a mental disorder, right? So that's important. Right. And this is different from that example that I gave you about uh, body dysmorph something, about the guy who was like Ken doll, and started doing all that stuff, right? Body dysmorphia or something. What was it? I'm not sure where that was, but anyways. I think it was all the way up there. Hold on. Nope. Okay, I'm gonna move past that now. not gonna get hung up on that. Anyways, sexual dysfunction. Also, it occurs in this as well, bulimia. Um, they're kind of obsessed with how they look, and that's why they're doing the purging, right? So, sexual dysfunction includes sexual desire disorder, hypoactive sexual desire or sexual aversion, sexual arousal disorder, erectile dysfunction, orgasmic disorder, anorgasmia, premature ejaculation, sexual pain disorder, and genital pelvic pain, penetration, and disorder. So, differential diagnosis include penis. P for psychological, if nighttime erections still occur. Okay, so they'll give you a question, and the scenario is going to be about some guy coming in concerned about, uh, why he can't keep it up. So he'll give you history, and the history will say that he does have morning erections, but when they're trying to get it on, it doesn't happen. So that's because it's psychological. Okay, so sexual dysfunction is psychological. It could be endocrine, for example, diabetes or low testosterone. It could be neurogenic, for example, post-operative or spinal cord injury. It could be because of insufficient blood flow, for example, atherosclerosis, or it could be because of substances, for example, antihypertensives, antidepressants, and ethanol. Okay, and you need to know which ones are, causing this and which one don't. And that's given in Farm of Psyche. Okay, we'll do it there. Sleep terror disorder. So periods of inconsolable terror with screaming in the middle of the night. Remember that was N3, night terrors. Most common in children, occurs during slow wave deep, stage N3. So it was V flee and V flee because it's scary in N3. That was the mnemonic for that. New non-REM sleep with no memory of the arousal episode, as opposed to nightmares that occur during REM sleep. Remembering a scary dream. Triggers include emotional stress, fever, and lack of sleep. Usually self-limited. Anuresis, this is nighttime urinary incontinence, more than 2 or more times per week for 3 or more months in person of more than 5 years old. So until 5 years old, if a couple comes in with a child who's complaining about bedwetting, and the child is only like 4 years old, you don't tell them something's wrong. You just tell them it's normal, okay? Because it's anuresis if it's still happening after 5 years old. First line treatment is behavioral modification, for example, scheduled voids, nighttime fluid restriction, and positive reinforcement. For refractory cases, bedwetting alarm, oral desmopressin, ADH analog, preferred over imipramine due to fewer adverse effects. Narcolepsy, excessive daytime sleepiness despite awakening well rested. Okay, this is an important one. So, excessive daytime sleepiness despite awakening well rested, with recurrent episodes of rapid onset overwhelming sleepiness 3 or more times per week for the last 3 months. And it's due to decrease in orexin or hypocretin production in the lateral hypothalamus and dysregulated sleep-wake cycles, associated with hypnagogic just before going to sleep or hypnopompic just before awakening. Get pumped up in the morning, so hallucinations. So if they get hallucinations right before they go to sleep or right before they wake up, they get hallucinations. Nocturnal or narcoleptic sleep episode that start with REM sleep, so sleep paralysis. And then there is cataplexy, a loss of all muscle tone following strong emotional stimulus, such as laughter. Yeah, so important thing here is this and uh, these three things. Treatment is good sleep hygiene, sleep schedule naps, regular sleep schedule, daytime stimulants, for example, amphetamines or modafinil, and or nighttime sodium oxybate, GHB. Not sure what that is. Substance use disorder, maladaptive pattern of substance use involving two or more of the following in the past year. Okay, so they have the tolerance to it or withdrawal from it, uh, intense distracting craving, using more or longer than intended, or persistent desire but inability to cut down, time consuming substance acquisition, use, or recovery, impaired functioning at work, school, or home, social or interpersonal conflicts, reduced recreational activities, one or more than one episode of use using involving danger, for example, unsafe sex, driving while impaired, and continued use despite awareness of harm. In the case of appropriate medical treatment with prescribed medication, for example, opioid analgesics, sedatives, stimulants, symptoms of tolerance and withdrawal do not indicate a substance use disorder. So all of this, you don't have to memorize it. You should already it should be obvious when it comes. They talk anything about this when they're talking about a drug. It's substance abuse disorder. It'll just come to you, right? What's important is this stuff. When they tell you that something about this, you need to know that that's not a substance use disorder. Okay, so in case of appropriate medical treatment with prescribed medications, right? So if they're coming in and telling you that it pains a lot, and you can see they are in pain and asking for opioid, it's because they're in pain. It's not that they're abusing the drug. Okay, and you will be asked questions like that. So you need to be able to point out if the person is, being factitious or malingering, or you know, it's genuine, right? Or do they have substance use disorder? Because symptoms of tolerance and withdrawal do not indicate a substance use disorder. Uh, Gambling disorder. So over there, they will also tell you that the person is trying to quit it, but then they were able to quit it for at least a week before they started getting withdrawals from it. Then it doesn't mean they have a substance use disorder. It just means they're trying to get over it, but they need help with it. Gambling disorder. Persistent, recurrent, problematic gambling that cannot be better explained as a manic episode. Diagnosis made if patient meets more than four or more of the following criteria. Okay. Is preoccupied with gambling, requires more gambling to reach desired level of excitement, has failed efforts to limit, cut back, or stop gambling, becomes restless or irritable when limiting or attempting to stop gambling, gambles to escape or relive uh, feelings of helplessness, guilt, anxiety, or depression after losing money gambling, continues gambling in attempt to recover losses, lies to conceal the extent of gambling, puts at risk or has lost significant relationship, career, or academic pursuits because of gambling, relies on money from others to fix financial collapse due to gambling. Treatment is psychotherapy. Okay. Don't need to memorize it. Just reading about it, you can tell that it's gambling disorder. Okay, this is important. Uh, the trans-theoretical model of change, uh, and you need to be able to, if they give you a scenario, you should be able to tell at which stage the person is in. Okay. So pre-contemplation, it's they deny the problem and its consequences, so they haven't been even started this, you know, the change. Okay, so motivational strategies encourage introspection, use patients' personal priorities in explaining the risks, and affirm your availability to the patient. And then there's contemplation. So this is where he starts, acknowledging it, that he has a problem. So contemplation is acknowledges the problem but is ambivalent or unwilling to change. So it's like, I know I have a problem, doctor, but I can't do it at this time, and so that's contemplation. So discuss pros of changing and cons of maintaining current behavior, and suggests means to support behavioral change. Then there's preparation or determination. So committed to or planning for behavior change, right? So they bought like a gym membership, or they bought new shoes to go running, to, you know, something like that, to lose weight. Employ motivational interviewing. So encourage initial changes. Promote expectations for positive results. Provide resources to assist in planning. Okay. So they're like, yeah, in a week I'll lose 10 kilograms, right? So then you gotta tell them that right now let's just focus on running and seeing how it makes you feel. And even if you're doing like, half a kilometer, that's still an achievement. That's even better than what we expect of you, or something like that. I don't know. So like that stuff. Okay, so preparation and determination. So far we did pre-contemplation, where they deny the problem and its consequences. Contemplation is they understand they have a problem but they don't do anything about it. And then preparation and determination is where they know they have a problem and they're trying to, they have a plan in place to put in action, right? And then you put the plan in action. That's the action stage, or willpower. So executes a plan and demonstrates a change in behavior, assists with strategies for efficiency efficacy, contingency management, and coping with situations that trigger old behaviors. Okay, so they see someone smoking, and then they want to uh, they would get a craving and all that. So how do you deal with that? Maybe chew a gum, right? Nicotinics or something like that. uh, so putting it into action. And then there's maintenance. So new behavior becomes sustained, integrate into personal identity and lifestyle. Reinforce developing habit, evaluate and mitigate relapse risk, praise progress. And that's important. So if they're maintaining it, just all you have to do is just acknowledge their change and the effort they have been putting in. Reinforce the developing habits, evaluate and mitigate relapse risks, right? So you gotta be vigilant about that. You gotta see how this man can, or this person, or this woman can, relapse. And if the scenario says that you have done everything, what else can you do? Just praise the progress, I guess. Relapse is regression to prior behavior and does not always occur. So it varies based on degree of regression. Encourage return to change. Provide reassurance that change remains possible. Okay, so even if they relapse and they're like embarrassed about it and talking about it to you, you have to tell them that it's still not. It doesn't mean that it's there's no hope for you. It's just once we can still pick up, get back on the horse and continue with the progress. It's just one day uh, we can take care of it, you know. Psychiatric emergencies. These are serotonin syndrome, hypertensive crisis, neuroleptic malignant syndrome, delirium tremens, acute dystonia, and lithium toxicity, and tricyclic antidepressant toxicity. Um, the cause, manifestation, and treatment. So for serotonin syndrome, causes any drug that increases 5-HT. Psychiatric drugs are MAO inhibitors. It's the one with lean in it, or LINE, because you mow the lawn in a line, right? SSRIs and SNRIs, TCAs, vilazodone, vortioxetine, and buspirone. Non-psychiatric drugs are tramadol. You need to remember these ones. These are the most important ones. These ones are pretty obvious, but these ones they sneak up on you. Tramadol, ondansetron, triptans, linezolid, MDMA, dextromethorphan, pyridine, and St. John's wort. Manifestations are 3A's: increase in activity, neuromuscular, for example, clonus, hyperreflexia, hypertonia, tremor, seizure, autonomic instability, for example, hyperthermia, diaphoresis, and diarrhea, altered mental status. Okay, so altered mental status, autonomic instability, and increase in activity. Treatments are benzos and supportive care, cyproheptadine, 5-HT receptor antagonist. Okay, so you just block it out. If no improvement. Prevention is avoid simultaneous serotonergic drugs and allow a washout period between them. Okay. Hypertensive crisis. Eating tyramine-rich foods, and this is important one. You need to remember which ones these are. It's aged cheese, cured meats, wine, and chocolate. Scenario is gonna have someone drinking wine with cheese, okay, and then they went into a hypertensive crisis, so it's because of that. While taking MAO inhibitors, so they'll ask you what could the cause be, and the cause is that they're on MAO inhibitors. Insufficient washout period when switching antidepressants to or from MAO inhibitors. Hypertensive crisis. So tyramine displaces other neurotransmitters, for example, norepinephrine, in the synaptic cleft. So that will lead to increase in sympathetic stimulation. Treatment is phentylamine for that. Okay. Neuroleptic malignant syndrome. This is This is due to antipsychotics, typical more than atypical one, plus the genetic predisposition factor. With this one, you have malignant fever. Okay. So myoglobinuria, fever, encephalopathy, vitals are unstable, increase in enzymes, for example, CK, and muscle rigidity. So lead pipe rigidity. That's different than the Cogville one that you see in the other thing. Okay, Parkinson's. So, and remember at least the malignant fever, hyperthermia, because they will give you that, and they will give you CK levels or myoglobinuria somehow, and because vitals unstable, that could be anything. That's not going to give it away. Encephalopathy can be because of anything, but malignant fever, not many things can cause that, and same for myoglobinuria. So if they tell you the person was, has symptoms of psychosis, and then you just imagine or assume that they're on antipsychotics, and that can cause neuroleptic malignant syndrome. Dantrolene, dopaminergics, for example, bromocriptine, amantadine, benzodiazepines, discontinue causative agents. Okay. Delirium tremens, this is because of alcohol. Okay, so alcohol withdrawal. Okay, so you tremor because of alcohol withdrawal. That's how I remember that one. So alcohol withdrawal occurs 2 to 4 days after last drink. We'll do that over here. So alcohol withdrawal occurs 2 to 4 days after last drink. Okay, classically seen in hospital setting when inpatient cannot drink, right? Because they can't sneak in a drink or alcohol in the hospital. So then after 2 to 3 days or 4 days, they'll start having all the symptoms. And one of the symptoms are delirium. Okay, so what will you see? You'll see altered mental status, hallucination, autonomic hyperactivity, anxiety, seizures, tremors, psychomotor agitation, insomnia, and nausea. Treatment for this is longer acting benzos. Okay. Acute dystonia, typical antipsychotics, anticonvulsants, for example, carbamazepine and metoclopramide. This is important that metoclopramide can cause acute dystonia, and same for carbamazepine. So what is acute dystonia? It's sudden onset of muscle spasms, stiffness, and or oculogyric crisis occurring hours to days after medication use. Okay, it can lead to laryngospasm requiring intubation. So that's important. Treatment is benztropine or diphenhydramine. Okay. Lithium toxicity. So it's caused by increase in lithium dosage or decrease in renal elimination. For example, acute kidney injury. Medications affecting clearance. For example, ACE inhibitor, thiazide diuretics, and NSAIDs. Okay. They have a narrow therapeutic window. Lithium toxicity is important, not only for this, but also for the effect it has on a fetus. So know about those as well. The Epstein anomaly. Nausea, vomiting, slurred speech, hyperreflexia, seizure, ataxia, nephrogenic diabetes insipidus. Okay, you'll see all of these things. Treatment is just discontinue lithium, hydrate aggressively with isotonic sodium chloride, and consider hemodialysis to filter out lithium. Tricyclic antidepressant toxicity, so TCA overdose, respiratory depression, hyperpyrexia, prolonged QT. Okay. Tricyclics, so it has 3 C's. C's for convulsions, coma, and cardiotoxicity, because arrhythmia due to sodium channel inhibition. Supported treatment, monitor ECG, sodium bicarbonate prevents arrhythmia, and activated charcoal. So 3 C's you'll see are convulsion, coma, and cardiotoxicity. Psychoactive drug intoxication and withdrawal. Okay, so drug intoxication and withdrawal. Depressants, so non-specific mood elevation, decreased anxiety, sedation, behavioral disinhibition, and respiratory depression. This is why it's called depressant. Okay. So you would think, why do people drink alcohol if it's causing depression? If it's a depressant, it's a depressant because of respiratory depression, but they do elevate the mood. Okay, they decrease anxiety, and all the inhibitions are gone. So because of that, withdrawal, non-specific, anxiety, tremor, seizures, and insomnia. This is a common theme amongst the withdrawal of things. Okay, alcohol. Alcohol intoxication is emotional liability, slurred speech, ataxia, coma, and blackouts. Serum gamma glutamyl transferase or GGT, a sensitive indicator of alcohol use. AST value is 2 times ALT value, so toast to alcohol. That's how I remember that. We did that in GIT. Treatment supportive, for example, fluids and antiemetics. Treatment is longer acting by benzos. Okay, so for alcohol, the tremors, insomnia, and all that stuff starts at like the 3rd day. Withdrawal will start at the 6th day, and alcohol hallucinations will start at the 12th day. And that's why even if someone wants to quit, they can't without help. And normally on the streets, they want to quit, but they can't. And that's why they keep drinking. Because when they attempt to quit, they start getting all these things that is worse than, just going ahead and drinking it. Okay, and then, sorry, not days, hours. Wait, is that hours? From the last drink, you start getting tremors in 3 hours? That can't be right. Okay. I'll pick that up later. Okay. So that means this is starting in a day. That seems wrong, but anyways. Because even here they told us for in the delirium, it's going to be 2 to 4 days after that they start getting delirium, right? And here it's time from last drink in hours. Doesn't mean. Oh wait, that's delirium tremens. Okay. So I guess follow this. So delirium tremens, I thought it was all of these symptoms, but that's just something else. Okay, so 3 hours you start getting tremors, insomnia, diaphoresis, agitation, and GI upset. Then within 6 hours you start getting withdrawal seizures and alcoholic hallucinations. After that occurs at 12 hours, and then 48 hours you get delirium tremens. That seems extreme, man. Barbiturates, low safety margin, marked respiratory depression. Treatment is symptom management, for example, assist respiration, increase in blood pressure. Delirium, life-threatening cardiovascular collapse. Okay. That's the withdrawal. So you get delirium, life-threatening cardiovascular collapse. Intoxication, this is the important thing, marked depression. Okay. For these, it's important to know which receptors they affect. At least for opioids, they affect the mu receptors. Okay. For the other ones, I guess it's not important. Benzodiazepine, greater safety margin, ataxia, minor respiratory depression. Treatment is flumazenil. That's important to know. It's an antidote to benzo overdose. So benzoreceptor antagonist, that's what it is, but rarely used as it can precipitate seizures. Withdrawal of benzos will cause seizures, sleep disturbance, and depression. Okay. Opioids, pupillary constriction, pinpoint pupils, decreased GI motility, respiratory and CNS depression, euphoria, decrease in gag reflex, seizures, most common cause of drug overdose and death. Opioids cause pinpoint pupil, so that's important. They act on, they do two things. They depress adrenergic and cholinergic effects. Okay. They do both of those. So it pinpoint pupil, you get that. Decreased GI motility. It slows down the motilin receptors. Respiratory and CNS depression. Again, same thing. Euphoria and gag reflexes decrease, and seizures. Most common cause of drug overdose, death. Overdose treatment is naloxone. Okay. You need to know what you would give in a neonatal abstinence syndrome, right? You give methadone, and I forgot the other one, but yeah, methadone is like number one, and then I guess the other one was naltrexone or something like that. Okay. So opioid withdrawal will give you dilated pupil. Okay. It's not that it's dilated, it's just that it's no more pinpoint, so it looks dilated. Because it, again, opioid only act on mu receptors, they don't act on adrenergic or the other ones. But because opioid inhibits it, so when you take away opioids, what happens is your body overcompensates for all the things, so it's gonna make more acetylcholine and all that stuff. So that's gonna lead to dumbbells, right? So dilated pupil, diarrhea, rhinorrhea, yawning, nausea, stomach cramps, sweating, piloerection, cold turkey, and lacrimation. Treatment and symptom management: methadone and buprenorphine. Inhalants. Although this is adrenergic, it's not cholinergic effect. Okay. But similar concept with that as well. Inhalants: disinhibition, euphoria, slurred speech, disturbed gait, disorientation, and drowsiness. Effects often have rapid onset and resolution. Perinasal, perioral rash with repeated use. So it's gonna be a guy brought in by his mother. It's gonna be like 16 years old, and they're sitting in the clinic, you know, all chilled out. They look high, or they seem high. Then the doctor, he responds to doctor. He's like, being responsive. He's not being mean or anything, nor aggressive. He answers the questions, but the mother's all complaining about him being aggressive at home and all that stuff, right? So when the doctor goes in and does a closer look, closer examination, he sees crusting near the nose, between the nose and the upper lip, and that's a buzzword for inhalants, right? He's probably inhaling petrol or something, or they take a piece of cloth and then dip it in something like petrol, or they put in glue and then they huff it, and that causes repeated use will cause perinasal or perioral rash. Okay. So withdrawal of that will be irritability, which the mother complains of, right? Dysphoria, sleep disturbance, and headache. Stimulants. So these are non-specific symptoms you'll see are mood elevation, decrease in appetite, psychomotor agitation, insomnia, cardiac arrhythmias, tachycardia, and anxiety. Non-specific withdrawal symptoms are post-use crash, including depression, lethargy, increase in appetite, sleep disturbance, and vivid nightmares. Okay. Amphetamines: euphoria, grandiosity, pupillary dilation, prolonged wakefulness, hyper alertness, hypertension, paranoia, fever, fractured teeth, skin excoriation with methamphetamine use or meth. Severe symptoms are cardiac arrest or seizures. Treatments are benzodiazepines for agitation and seizures. If you've seen Breaking Bad, you're aware of this stuff. Caffeine, palpitation, agitation, tremor, and insomnia. It can also precipitate PSV, right? Proximal supraventricular tachycardia, PSVT, right? Oh, PVT, PST. Okay, but yeah, proximal supraventricular tachycardia. It can precipitate that as well. If you have it, a condition that has that, someone has that. Okay. Caffeine withdrawal is headache, difficulty concentrating, flu-like symptoms. Okay. Psychoactive drug continuation, cocaine. So intoxication, impaired judgment, pupillary dilation, diaphoresis, and hallucination. Okay. Including tactile paranoia, angina, and sudden cardiac death. Chronic use may lead to perforated nasal septum due to vasoconstriction and resulting ischemic necrosis. Right, because this is a alpha drug. So, what does alpha do? Right, it's alpha 1 is known for vasoconstriction. So when you give cocaine, it vasoconstricts everywhere. In a chronic use, what will happen? Ischemia. Ischemia will lead to necrosis. Necrosis will lead to perforation of the nasal septum because they sniff cocaine, right? Plus, if they're on cocaine, you shouldn't give beta blockers because only thing that's balancing out or at least attempting to reduce the alpha effect is beta. So if you give beta blockers, what's gonna happen? Then there's gonna be unopposed alpha action, right? Because why beta? Because what does beta 2 do? Beta 2 is a vasodilation one, right? So treatment: benzodiazepines. Use beta blocker or mixed alpha and beta blockers, for example labetalol. Okay. For hypertension and tachycardia, with controversial as first line therapy. Right, so that's what they're saying. Use of beta blockers or mixed alpha beta blockers for hypertension or tachycardia is controversial as first line therapy. So don't give it because they'll come in. If they're on cocaine, they'll come in with palpitation or tachycardia and stuff, right? So you might think giving them beta blocker, but it's important to know what drug they were on, because if you give this and they're on cocaine, there's going to be an opposed alpha action because of that. Withdrawal of cocaine will lead to restlessness, hunger, severe depression, and sleep disturbance. Nicotine intoxication is restlessness. Withdrawal of it will be irritability, anxiety, restlessness. So you take it, you get restless. You don't take it, you get restless. Decrease in concentration, increase in appetite and weight. Treatment is nicotine replacement therapy, for example, patch, gum, and lozenge. Bupropion and varenicline. Okay. Hallucinogens, LSD or lysergic acid, diethylamide. Okay. You need to know what what it does, like what the clinical picture will look like with these, right? Especially for PCP, because there's only one thing they'll tell you, and that's like the buzzword. It's violent tendencies, or he was punching and kicking and stuff after taking a substance. So what substance was it? It's going to be PCP. Okay, so LSD, perceptual distortion, visual auditory depersonalization, anxiety, paranoia, psychosis, flashbacks, usually non-disturbing, and it will cause mydriasis. Cannabis or cannabinoids or weed, it gives them euphoria and anxiety, paranoid delusions, perception of slowed time, impaired judgment, social withdrawal, increase in appetite, dry mouth, conjunctival injection, hallucinations, okay, and irritability, anxiety, depression, insomnia, restlessness, and decrease in appetite for withdrawal. MDMA, also called ecstasy, euphoria, hallucination, disinhibition, hyperactivity, increase in thirst, bruxism, that's teeth uh, grinding, right? Remember which stage it's in. It's the one that causes which kind of wave. The sleep spindle and K complexes. Okay. It's the second stage, was it? Oh. Yeah, I think it was the second stage, N2. Distorted, because the first one was theta and that was useless. Second one was this, and third one was N3 with the V flee and V flee from N3 because it was scary. Okay, back to this. Distorted sensory and time perception, mydriasis. Life-threatening effects include hypertension, tachycardia, hyperrhythmia, hyponatremia, and serotonin syndrome. So if they give you bruxism or increased thirst or euphoria or something like that, it's MDMA. They don't usually, I haven't came across one with cannabis use, so they didn't test that. They have tested this one, and the way I figured it out, it was because of flashbacks. So flashbacks can occur like it could be a day or month or even a year after their use of LSD. Okay. For MDMA, yeah, bruxism gives it away. Okay. Withdrawal of it will be depression, fatigue, change in appetite, difficulty concentrating, and anxiety. PCP, it's the easiest one to figure out because violence, nystagmus, impulsivity, psychomotor, agitation, meiosis, and tachycardia. They might give you all of this, but you cut off you trim the fat and then you look at the meat. And the meat of this is violence. Okay. Tachycardia, hypertension, analgesia, psychosis, delirium, and seizures. Alcohol use disorder, diagnosed using criteria for substance use disorder. Complications: vitamin B1 or thiamine deficiency, alcohol cirrhosis, hepatitis and pancreatitis, peripheral neuropathy, testicular atrophy. Okay. So that's an important deficiency that you need to know. Everything else is pretty obvious. Right? Pancreatitis is an important one that you should know as well. Treatment is naltrexone, reduces cravings. Acamprostat and disulfiram to condition the patient to abstain from alcohol use. We just recently had a question on the group about, someone who's alcoholic and is on opioid use. So what would you give them? You would give them this one, Acamprostat. Okay, because you shouldn't drink while being on opioid because the symptoms are worse for the side effects of that. So give that. Support groups such as Alcoholic Anonymous which are helpful in sustaining abstinence and supporting patient and family. So that's pretty good too. Wernicke-Korsakoff syndrome. So it results from vitamin B1 deficiency. Symptoms can be precipitated by administering dextrose before vitamin B1. Okay, so if they're given dextrose before this, it can precipitate the symptoms. Why is that? It's because when they come in, they're gonna be malnourished or basically not have any energy, right? Any ADP forming or something like that, because they're going to be hypoglycemic. Why hypoglycemic? I explained that I think in the biochem section. So basically, when you give dextrose, there will be glycolysis happening, right? Okay, and as glycolysis happens, everything is going to be used up. Okay, and the most important thing for once it becomes pyruvate and goes into acetylcholine, the cycle, citrate cycle, it requires pyruvate dehydrogenase, right? And this is time independent as well. Okay, and because of that, if you don't give thymine and you give dextrose before giving thymine, it's gonna precipitate the symptoms because you still don't have ATP. You're not making any ATP anymore still, because this one requires thymine and you're thymine deficient. Okay, and that's why. So results from vitamin B1 deficiency symptoms can be precipitated by administering dextrose before vitamin B1. So the triad is confusion, ophthalmoplegia, and ataxia. It's called Wernicke encephalopathy. It may progress to irreversible memory loss, confabulation, that's just muttering or making up stories, right? Engage in conversation, she could be heard on the telephone, confabuling, and so on. It's just, making up stories. Personality that changes, Korsakoff syndrome. Okay, treatment is IV-B1 or thymine before giving dextrose. Okay. Psychiatry. So psychotherapy. So these are all the terms we came across, and it just explaining them now. Behavioral therapy. It teaches patient how to identify and change maladaptive behaviors or reactions to stimuli. For example, systemic desensitization for specific phobia. Okay. Cognitive behavioral therapy it teaches the patient to recognize distortions in their thought processes, develop constructive coping skills, and decrease maladaptive coping behavior. Okay. This leads to greater emotional control and tolerance of distress. For example, recognizing triggers for alcohol consumption. So this one was in the thought process, right? Identify and change maladaptive behavior or reactions to stimuli. Okay, so this is about the reaction. This one's about the thought process then. Okay. Alright. Delectable behavioral therapy. Designed for use in borderline personality disorder, but can be used in other psychiatric conditions as well. For example, depression. Okay. Leading to logical discussion of ideas and okay. So dialectable. Okay. So designed for use in borderline. Okay. But can be used in other depression. Okay. Interpersonal therapy. This is focused on improving interpersonal relationships and communication skills. Motivational interviewing. It enhances intrinsic motivation to change by exploring and resolving ambivalence. Okay, it's used in substance use disorder and weight loss. Okay, and supportive therapy utilizes empathy to help individuals during a time of hardship to maintain optimism or hope. Okay, so that's like the Alcoholic Anonymous. Okay, motivational, it's about weight loss. So when they have the gym membership and they put in like 30 minutes of work in it, you praise that work. That's called motivational. Interviewing, right? All that stuff. Preferred medication for selected psychiatric conditions. For these, let's do this afterwards because we need to know about what SSRIs do and SNRIs do and all of these drugs, right? So we'll come back to this later. How will we remember? Let me just make a thing and I'll put it to the side. Central nervous system stimulants: methylphenidate, dextroamphetamine, methamphetamine, and lisdexamphetamine. Okay. So methamphetamines basically. So those are stimulants. Mechanism is that it increases catecholamines in the synaptic cleft, especially norepinephrine and dopamine. Clinical use is ADHD, narcolepsy, binge eating disorders. Okay. So that's the clinical use. Remember, in ADHD, it seems awkward that you would give a stimulant to someone who's already hyper, but you gotta remember that we give it uh, in this. I'm not too sure why. I don't remember it. I think New World explains it, but I don't remember it right now. Narcolepsy, you give it in that because you keep falling asleep because of orexin. So methamphetamine is gonna keep you awake, and binge eating disorder as well. Okay, so adverse effect: nervousness, agitation, anxiety, insomnia, anorexia, tachycardia, hypertension, weight loss, tics, and bruxism are the adverse effects. Antipsychotics, typical first generation antipsychotics: haloperidol, pimozide, trifluoperazine, fluperazine, and azine ones, and chlorpromazine. Okay, so these are your antipsychotics, typical ones, first generation. And there are atypical ones, are also known as second generation antipsychotics. These are the ones with apine in it. Okay, so antipsychotics, so aripiprazole and acinapine, clozapine, olanzapine, risperidone. Yeah, so those three are the main ones: clozapine, olanzapine, and risperidone. Mechanism is that they block the D2 receptor. That's the inhibitory one, right? It increases CAMP. So atypical antipsychotics also blocks serotonin or 5-HT2 receptors. So okay, and aripiprazole is a D2 partial agonist. Clinical use is schizophrenia. Typical antipsychotics primarily treats positive symptoms. Atypical antipsychotics treat both positive and negative symptoms. Disorders with concomitant psychosis, for example, bipolar disorder, Tourette syndrome, OCD, Huntington disease. Clozapine is used for treatment resistant psychotic disorders or those with persistent suicidality, right? So close to the age. Adverse effects: antihistaminic or sedation, anti-alpha 1 and adrenergic. Okay, so that's vasoconstrictor one. So you're blocking that. So right, antihistaminic. That, so orthostatic hypotension because of vasodilation. Antimuscarinic, dry mouth constipation. Why vasodilation? Because there's unopposed action of beta adrenergic, because alpha 1 is blocked. Antimuscarinic, right? So opposite of dumbbell. So dry mouth constipation. Anti-ham, use with caution in dementia, metabolic, weight gain, hyperglycemia, dyslipidemia. Highest risk with clozapine and olanzapine or obesity. Endocrine, hyperprolactinemia will lead to galactorrhea, oligomenorrhea, gynecomastia. Cardiac, it will cause QT prolongation. Neurologic, it will cause neuroleptic malignant syndrome. That's the one with malignant fever and the other stuff. The CK, increase in CK, right? Ophthalmologic, chlorpromazine, corneal deposit, thioridazine, retinal deposits. That's an important one. They might give you that, and that should clue you in that it's a chlorpromazine. Okay. For clozapine, it's agranulocytosis. That's an important one. You need to know about that one. So monitor WBCs closely. Seizures are dose related and myocarditis. Extrapyramidal symptoms. So adapt hours to days, acute dystonia, muscle spasm, stiffness, oculogyric crisis. Treatment is benztropine and diphenhydramine. Okay. Those were the alpha ones. Alpha 2 agonists, I think. Right. Uh, alpha 2 or alpha 1 agonist, I think. Because it blocks this, so it would make sense that's that. Days to months. Ectasia, restlessness. Treatment is beta blocker, benztropine, and benzodiazepine. Parkinsonism, bradykinesia. Treatment is benztropine, amantadine. Months to years, tardive dyskinesia, chorea, especially orofacial. Treatment is benzodiazepine, botulinum toxin injections, and all of this stuff that doesn't matter. Okay. Notes: lipid soluble, stored in body fat, slow to be removed from body. So it's lipid soluble, so it goes and stays in your body for a long time because it can't be cleared off that easily, right? Typical antipsychotics have greater affinity for D2 receptor than atypical antipsychotics. It leads to increase in risk for hyperprolactinemia, extrapyramidal symptoms, neuroleptic malignant syndrome, high potency typical antipsychotics, haloperidol, trifluoperazine, pimozide, flufenazine. Okay, so this you need to know which ones are the high typical antipsychotics. So these are your, Hull tries pi to fly high. So Hull, try, pi, and fly. Okay, so they have more neurologic adverse effects. For example, extrapyramidal symptoms. And then the low potency typical antipsychotics are these: chlorpromazine, thyroidazine. Cheating thieves are low. Okay, so only two of them. So chlor and thigh. So it should be easy to remember that way as well. They cause they're more antihistaminic, anti-alpha 1 adrenergic, and anti-muscarinic effects. Okay. This is very important. They test you on this right here. Lithium. Mechanism, clinical use, and adverse effects. So mechanism is not established, possibly related to inhibition of phosphoinositol cascade, the PIP one. Clinical use is mood stabilizer for bipolar disorder, treats acute manic episodes, and prevents relapse. Okay. The adverse effects for lithium are important. So tremor, hypothyroidism, hyperthyroidism, mild hypercalcemia, polyuria. So hypercalcemia is important. That's caused by lithium. And if they give you that, there are not that many things that cause that. So lithium is one of them. Polyuria causes nephrogenic diabetes insipidus. Teratogenesis causes Epstein anomaly. Narrow therapeutic window requires close monitoring of serum levels. Almost exclusively excreted by kidneys. Most is reabsorbed by PCT via NA channels. Thiazide, ACE inhibitor, and NSAIDs and other drugs affecting clearance are implicated in lithium toxicity. Lithium, you have low thyroid, so hypothyroidism, heart, Epstein anomaly, insipidus, nephrogenic diabetes insipidus, and unwanted movements, so tremor. Buspirion, that's mechanism is partial 5-HT1A receptor agonist. Clinical use is generalized anxiety disorder, does not cause sedation, addiction, or tolerance. Begins to take effect after 1 to 2 weeks, does not interact with alcohol versus barbiturate or benzodiazepine. I get anxious if the bus doesn't arrive at 1, so I take bus Piron. Okay, so it's used for anxiety disorder. Okay, antidepressants, noradrenergic, and all this stuff. We'll look at that as we read about it. Okay. SSRI, or selective serotonin reuptake inhibitor, fluoxetine, aldoxetine, and sertraline. That these ones are the important ones. The prams, right? Escitalopram and citalopram, and sertraline. Those are the important ones. Okay, so mechanism is it inhibits 5-HT reuptake. Okay, so 5-HT reuptake is inhibited by SSRIs. Okay. Clinical use is depression, generalized anxiety disorder, panic disorder, OCD, bulimia, benign, binge eating disorder, social anxiety disorder, PTSD, premature ejaculation, premenstrual dysphoric disorder. Adverse effect is fewer than TCAs, serotonin syndrome, right? Because it has serotonin in the synaptic cleft for a longer time now. GI distress, SIAD, sexual dysfunction, anorgasmia, erectile dysfunction, decrease in libido, manic precipitation if underlying bipolar disorder. It normally takes 4 to 8 weeks for antidepressants to show appreciable effect. So you need to know the mechanism of action of this, and it's in the name, right? So they prevent the serotonin reuptake, right? So leaves that. So if there's more serotonin in the synaptic cleft, you get serotonin syndrome. Okay, yeah, you can use it for all of these things. Then you have SNRIs, or serotonin norepinephrine reuptake inhibitor, the venlafaxine, and all of these. I think that's the most important one. Mechanism is it inhibits 5-HT and NE reuptake. Okay, so here it's gonna, prevent reuptake of norepinephrine, so you have more of those, and you have more of serotonin as well. Its clinical use is depression, generalized anxiety disorder, diabetic neuropathy. Venlafaxine is also indicated for social anxiety disorder, panic disorder, PTSD, and OCD. Duloxetine and milnacipran are also indicated for fibromyalgia. Sure. Adverse effects: increase in blood pressure, stimulant effects, sedation, sexual dysfunction, and nausea. I guess this one is pretty obvious, right? So remember that one. Remember this one. Okay, so sexual dysfunction. So if a person comes in with a complaint of erectile dysfunction and he's taking any one of these, that could be the culprit. Tricyclic antidepressants: amitriptyline, nortriptyline, imipramine, desipramine, clomipramine. These are the important ones. Mechanism: TCAs inhibit 5-HT and norepinephrine reuptake. Clinical use is MDD, peripheral neuropathy, chronic neuropathic pain, migraine prophylaxis, OCD, so clomipramine for that. And nocturnal aneurysms, we give imipramine for that. Adverse effect is sedation, alpha-1 blocking effects, including partial hypotension, and atropine-like anticholinergic adverse effects, tachycardia, urinary retention, dry mouth. Tertiary TCAs, amitriptyline, have more anticholinergic effects than secondary TCAs. Nortriptyline, can prolong QT interval. So tricyclics, remember the 3 C's: convulsion, coma, cardiotoxicity, arrhythmia due to sodium channel inhibition. Also respiratory depression, hyperexia, confusion, and hallucination are more common in older adults, and due to anticholinergic adverse effects. So secondary amines, for example, this is better tolerated. Treatment is sodium bicarbonate to prevent arrhythmia. MAO inhibitors, so on the line ones, right? That's the important one. And repagiline or something like that. So these are the selective MAO-B inhibitors. Okay, so non-selective MAO inhibition increases level of amine neurotransmitters, so norepinephrine, 5-HT, and dopamine. Clinical use is atypical depression, anxiety, and Parkinson's disease. So for Parkinson's, you use that. Adverse effect is CNS stimulation, hypertensive crisis, most notably with ingestion of tyramine. Remember the tyramine-rich food, the wine and the cheese and all that stuff. Contraindicated with SSRIs, TCAs, and St. John's wort. Meperidine, dextromethorphan, pseudoephedrine, linezolid. To avoid precipitating serotonin syndrome, wait 2 weeks after stopping MAO inhibitor before starting serotonergic drugs or stopping dietary restrictions. Atypical antidepressants, so bupropion, it inhibits NE and DA reuptake. Also used for smoking cessation. So toxicity, stimulant effects, tachycardia, insomnia, headache, seizures in patients with bulimia, anorexia, nervosa. Decreased risk of sexual adverse effects and weight gain compared to other antidepressants. Okay, so when you're doing this, just pay attention to the mechanism of action by what the result will be. So usually the result is keeping things in the synaptic cleft, right? So the neurotransmitters. Mirtazapine, alpha-2 antagonists, increased risk release of norepinephrine and 5-HT. Potent 5-HT2 and 5-HT3 receptor antagonists and HT1 antagonist. So it's just alpha antagonist. Okay. And there are two A's, so A2 antagonist. And all the 5-HT1s as well. Okay, toxicity of sedation, which may be desirable in depressed patients with insomnia. Increase in appetite, weight gain, which may be desirable in underweight patients, and dry mouth. Trazodone, don't pronounce it like bone, so trazobone. Why? Because we'll see over here. Primarily blocks 5-HT2, alpha-1 adrenergic, and H1 receptors. Also weakly inhibits 5-HT reuptake, used primarily for insomnia as high doses are needed for antidepressant effects. Okay, so it's an antidepressant, this thing, right? And toxicity will cause sedation, nausea, priapism, and postural hypotension. So think trazodone or as trazobone due to sedative, so it has Z's in it, so you use it for insomnia, and it causes priapism, right? So and male specific adverse effects to that. This one, there's decreased risk of sexual adverse effects. So if someone is on this and they have sexual dysfunction, it's not because of the antidepressants, because this one is has a decreased risk of sexual adverse effects. Okay, whereas this one has adverse effects. Okay, and then we have varenicline or clean, nicotinic acetylcholine receptor partial agonist used for smoking cessation. Toxicity is sleep disturbance. Varenicline helps nicotine craving decline. Velazodone inhibits 5-HT reuptake, 5-HT1A receptor partial agonist. Okay, and I think we're done with this stuff. So MAO inhibitor, prevents MAO from breaking down, so it's longer in the system. Same thing with that, and yeah, mirtazapine did that one. Alpha 2 agonist. And yeah, we're done with this one. Okay, so inhibits 5-HT reuptake 5-HT1A receptor partial agonist, used for MDD. Toxicity is that, and headache, diarrhea, nausea, anticholinergic effects may cause serotonin syndrome if taken with or other serotonergic effects. Vortioxetine inhibits 5-HT reuptake, 5-HT1A receptor agonist, and 5-HT3 receptor antagonist, used for MDD. Toxicity is nausea, sexual dysfunction. So mostly all of them has some kind of effect on sexual function, except for bupropion, because it specifically tells you that there's decreased risk of that. Okay. So that may cause a serotonin syndrome if taken with other serotonergic agents. Opioid detoxification and relapse prevention. This is important concept. Injection drug use, increased risk for hepatitis B, C, and HIV. Skin and soft tissue infections, bacteremia, and right-sided infective endocarditis. Okay. Methadone. It's long-acting oral opiate used for heroin detoxification or long-term maintenance therapy. Buprenorphine, partial opioid agonist, sublingual form or film used to suppress withdrawal and for maintenance therapy. Partial agonists can precipitate withdrawal symptoms in opioid-dependent individuals or when administered shortly after use for a full agonist. Naloxone, that's short-acting opioid antagonist given IV or as a nasal spray to treat acute opioid overdose, particularly to reverse respiratory and CNS depression. And naltrexone, that's long-acting oral opioid antagonist used after detoxification to prevent relapse. Okay, so treated for a long time. Okay, and may help alcohol and nicotine cessation and weight loss. Use naltrexone for the long treks back to sobriety. Okay, and done with psyche. Oh wait, we gotta do this thing. Where was it? Right, this thing. So preferred medication and selected psychiatric conditions. So for ADHD, we give stimulants, methylphenidate and amphetamine. For alcohol withdrawal, we give benzos, right? So benzodiazepine, for example, chlordiazepoxide, lorazepam, diazepam. For bipolar disorders, we give carbamazepine. Atypical antipsychotics, lithium, lamotrigine, and valproate. Forget that. So valproate, lamotrigine, lithium, antipsychotics, and atypical antipsychotics, and carbamazepine. Okay. For bulimia nervosa, we give SSRIs. Depression, we give SSRIs. For generalized anxiety disorder, we give SSRIs and SNRIs. For obsessive compulsive disorder, we give SSRIs, venlafaxine, and clomipramine. Panic disorder, we give SSRIs, venlafaxine, and benzodiazepines. PTSD, we give SSRIs as well, venlafaxine as well, and prazosin for nightmares. Schizophrenia, atypical antipsychotics. Social anxiety disorder, that's SSRIs, venlafaxine. Performance only, that's beta blocker and benzodiazepine. So that's when they're trying to perform on stage or something. Great. And Tourette syndrome, antipsychotics, for example, fluphenazine and risperidone, tetrabenazine. And yeah, I'll take a look at what that was again. Venlafaxine is a SNRI, right? So instead of writing that, you can just write SNRI in all of these. So SSRIs and SNRIs for at least these ones. and this one as well. Okay, and we're done.